So you're ready to go.
So I'm all fresh.
Oh, dang. We're going to have to
See how much I retain.
We're going to have to unprogram.
Yeah, retroactive interference.
No drugs.
Proactive interference.
So I wanted first, just how long do you want us to go?
Well, so why don't we go around first and just make
And
quick
do
introductions, just so everybody knows clinically who people are, and then so we have until 12. Lunch is being brought into this room. I apologize. Coffee was supposed to be here already and some fruit, but it's on the way. I called to Maggie. So yeah, why don't we do that? Okay. So okay, I'll start. So I'm Sherry Evans. I'm a senior technical advisor for maternal health at Chicago, and I've been here about almost 2 years, maybe 18 months or so. And I have been working on the bleeding after birth materials.
My name is Leah Hart. I am my technical development officer in the Global Learning office. And I've been here since this past June. I'm also finishing up my dual master's in public health nursing.
And your nursing background is critical
My
care.
my clinical experience is in oncology nursing at Mercy Medical Center, and I've been there for 2 years.
And still practicing.
Yeah.
Still doing it all
Adult.
at Mercy.
And everybody knows I'm Peter. I'm the director of the Global Learning Office, and I think I've been Sherry's partner in crime on the bleeding after birth and thinking through the Helping Mothers Survive strategy since the beginning. So, glad Sherry's
And I
here.
forgot to say I'm a midwife. I think you guys right away.
That's right.
I'm a midwife.
Be thinking about your personas already.
And my name is Laura Fitzgerald. I'm a maternal health advisor with Chicago and trained as a nurse midwife, but I kind of took a foray into programs. I've been at Chicago for about 4 years and was with the HIV team, and then I was serving as our country representative in Swaziland and just back, dusting off this clinical hat. So, happy to be here.
My name is Tiana. I'm going to finish up the Bachelor's in Nursing program at Johns Hopkins. And right now I'm finishing my final rotation at the Acute Care Center in Howard County General Hospital. So hopefully I'd like to work in OB when I graduate.
And I'm Susan Biermeyer. I'm a neonatologist by night and a volunteer for the American Academy of Pediatrics by day. So I'm the editor of Helping Babies Breathe, and I'm working now as kind of the liaison to another AAP group that's developing materials for essential newborn care, ENC, which is newborn care, taking it from the immediate postpartum period that Helping Babies Breathe covers through the first week, and then also being a liaison to helping mothers survive bleeding at birth, mainly for the editorial style and trying to keep training materials consistent across those programs. Do you want to introduce yourself as your Ugandan personas here?
I haven't been to Uganda yet, so I'm not familiar.
I just thought it would be useful to try to do this as we might, be facing circumstances in Uganda, because we really try to localize the teaching as much as possible. Peter, have you been in Uganda?
Mm-hmm.
Can you give us a sketch of what
the health
a typical training of providers might, what our setting might be?
I actually did a couple of very early trials with mamaNatalie on our after our first round of bleeding after birth materials were ready, and so it was in a very rural facility, and I can tell you exactly what it looked like. We went about 2 hours outside of Jinja, which is down along up along the lake, and went in lowest level that's attending births. And we asked them ahead of time. We were working with a faith-based organization that had rounded up the people for us at the facility, and we had asked them to bring everybody that was engaged in providing maternal health on the day of birth to this meeting. And when we got there, the training site consisted of probably about a 20-bed ward where 10 beds on each side, where they had pushed all the beds out to the side, and people were sitting around the outside on the beds, lined up as kind of like a big circle seating. And they had brought a table in for us to do the training and a couple of chairs. And the participants were there was 2 midwives, but those 2 midwives were not there all the time. They were scheduled, and so they didn't have 24/7 coverage of midwives, and they told us. But the 2 midwives that were there, and then we had a nurse, and we had a couple of housekeepers that were actually attending births at the facility, and a couple other people that I don't remember what their roles were, but they were very not skilled. They weren't skilled workers. There were a lot of people there that weren't skilled workers, but it was really clear that they had an essential role to play in some place along the line of making sure that people got care and got transported when they were needed.
Was there any equipment there for babies?
No, there wasn't, and we asked about about the equipment that they use, and then they told us that they use oxytocin. They told us that they about the equipment supplies that are on our list, and we went out. We asked them to go get it for us so we could use what they had for their for the training, and they couldn't find it. And then we did another training in Jinja and we just invited we just put a sign up on a town and in town, and we and it was like anybody who wants to show up can show up, and we had a lot of the missionary community show up. It's a big missionary community there, and we went to get misoprostol from the pharmacy because we wanted to be able to show it, and when my wife went to get the misoprostol, they wouldn't give it to her.
But they had it.
They had it, and they wouldn't get. They eventually did after she explained it, because it's used for abortion, and they eventually did. But it was really clear that it would be really typical. It would really be difficult for a provider in that context to get it.
So that was revealing.
And I think that was probably pretty typical of what you're going to see at the
level 2s.
Yeah, and then we looked at last year, another thing we did was we looked when we were writing a proposal, not for this but for another product, for a pre-service project. We looked at the level 2, level 3, level 4, and referral facilities that were in Uganda and the number of births. And I was really struck by the percentage of births when you add up all the level 2 facilities that are occurring at that level of the health system. It's not a small piece of the pie that's occurring out there. So,
well, I don't know if you want to reintroduce yourself as your Ugandan persona. It might be your clinical role that you have here, but translated into that setting. So I'll introduce myself. I'm Susan Niermeyer, and I'm a pediatrician, and I volunteer with the American Academy of Pediatrics to help facilitate these courses in helping babies breathe. I'd like to know each of you, your roles, and what brings you to this workshop today.
Okay, so I can't think of a Ugandan name.
You can be sharing, because I'm not going to be able to remember your Ugandan name.
And I'm a midwife in a level 2 facility here to help women and babies survive. And this workshop is about babies who don't breathe at birth, and we do see that.
Okay. My name is Leah, and I'm a nurse with 4 years of the equivalent of 4 years of training, and that would mean that I have training to be a midwife incorporated in the curriculum, I think. But I still would like to know, with very few resources, how do we make sure that we're still helping babies survive?
I'm the note taker. I'm the program officer. Looking at the impact.
No, and usually there is that person at these workshops. So you're from the district ministry?
Yeah, yeah, that's right. I'm from the district.
My name is Laura, and I am a newly trained, newly deployed midwife who actually did not get these skills in my training, but I'm seeing a lot of asphyxia in practice, and so I'm hoping to...
By the way, I'm going to make sure you all get your per diem, okay?
Oh, thank you so much, because that's also why I'm here.
And thank you for getting up early so you could be here on time this morning.
Hi, I'm Tiana. I'm graduating from the nursing school to help work in this level 2 facility, and I guess I would be also training to practice in the midwife role.
So you're actually still in
I'm
your
still studying.
training. Wonderful. Great. Well, we have a wonderful mix of people in this workshop, and part of the whole idea of this is that we share experiences among one another. So people who've had experience in the clinical area, you can really share with us some of the problems that you've encountered, some of the solutions. Other people who are just entering this, we appreciate your fresh eyes on this and the questions that you can ask that will help all of us understand it better. We were hoping to have Dr. Sangvi here from the Ministry of Health at the central level to share some of the information about baby survival in Uganda, but he left me some notes, and I think what he wanted to do was just emphasize that babies dying in Uganda are still a really important problem. So when we look at children under 5 years who are dying in Uganda, it's still about 100 babies out of every 1,000 born, or 1 in 10 babies will die by the time of their 5th birthday. And about 1/3 of those actually die as newborns. So that's really what we're here to change, is to try to help those babies get a really good start at birth and to prevent those deaths in the first days and months of life, because that's when a lot of babies die in Uganda. What's another difficulty here in your area? How many women deliver in the facility, in this level 2 facility, as compared to deliver at home? Do you have an idea?
So we have, so this level 2
I
facility, I think they're
can
pretty...
look at our program numbers here from the district, and I think the last month we delivered 80 babies at the, at this, no.
That's a lot.
It is,
isn't
it is.
for level 2?
Yeah, no, it's, well, no, some of them are 80, but this one's 40.
Okay.
This one's 40, and that's pretty consistent during there seems like there's a dip during the rainy season. And we know that probably there's about 3 or 4 times more of that number of births that are still occurring at home. We can't get to the facility.
Yeah, that would be pretty consistent with some of the statistics that Dr. Sangvi provided, where maybe 38 or 40% of births occur in the facilities, but the majority of births still occur at home. And is really a shortage of trained providers at birth. So this program, we hope, is going to be able to really extend into communities and increase the number of healthcare workers who have skills to attend babies at birth, and can increase that percentage of women who have somebody skilled at their delivery, not only to help them with the process of birth, but to attend to their baby as well. And you commented that you really haven't gotten this in your undergraduate
just
studies yet.
very little in my undergraduate. Only a few weeks to actually a month was devoted to that.
Yeah, good.
I think so.
Well, I hope this will fill a niche for you.
Yeah. I'm doing the doula program to get more bedside experience and birth experience too.
Good. Well, one of the ideas is that this program could even be taught in the schools of nursing and
Absolutely.
midwifery. So, all right. So I want to start with a little visualization exercise. So I'd like each of you, we're going to work in pairs. So you two will be working together with the simulator, and you two sharing. Yeah, so if you want to put the baby in between the two of you here, and I'd like for you to put a hand on the baby and close your eyes for a minute while I paint a couple scenarios. So close your eyes and imagine that a baby is born. The baby's not breathing, and there is no one to help the baby. And the baby dies. So keep your eyes closed. And now imagine that another baby is born. The baby's not breathing, but you are there to help the baby. You rub him dry, keep him warm, and help him breathe with a bag and a mask. And the baby begins to cry. Now open your eyes. Great. So have you ever been in that position?
Absolutely.
What was the situation?
My Ugandan situation, we don't have bags of buses. So babies, when they're born, maybe it's God's will, they're not breathing, so we just wrap them up and zip them inside. And that's sad. Sometimes we see blankets start moving and we realize that maybe the baby needed something a little more, and we'll go get it, and it's fine. But they don't do that.
And Sherry's really pointed out exactly the kind of situation where this program can be helpful. So what we want to do is not only give you the equipment that will allow you to help those babies, but give you the skills to know when a baby needs help and how you can intervene with some very simple steps that will help the baby breathe. Does anybody else have any experiences that they want to share? We really, as we go along, we want you to ask questions, contribute to your experiences, because we all really do want to learn from one another. And I'm going to say that we were supposed to have squeakers in these kits, and these are not really very complete.
I have a squeaker if you want it.
Yeah.
A squeaker?
Peter, we may have to cannibalize.
That's fine, that's why we have more.
I'm afraid we got
I have just one.
the display copies of our materials.
Just a parking lot issue, and actually we talked about maybe, having
Putting up a board.
a place for parking lot things
Yes.
during the time we're here, and I'll put them on a piece of paper for that.
Okay, do you want,
I'll start at the back, but I think it'd be good to talk about lost parts that are
Lost
needed
parts.
for training, because I think it's going to be an issue for all of us. And
Yeah.
Peter, would it be easy?
Have a learner's workbook, and on the back of that is our action plan. You'll see we have a big copy of the action plan up here too. And right now, to assemble our equipment, I'd like for you to focus on this bottom corner here where we have prepare for birth and have a list of the supplies and equipment that you need to prepare. So why don't you open your boxes and take out the equipment that we're going to be using. This is the carry bag that you can take all of this home in, but we won't be needing that right now. So you've got a stethoscope, you should have that. Let's see, do you all use gloves here at this facility?
So, when we have them, or when we have a box.
Now, this piece, you'll notice, isn't on your equipment list, and this was actually from an earlier version of the simulator. We used to put some air in as a final filling, and to keep the air from gurgling around, this was the bladder that was used to contain the air. But we really don't need this anymore. Laura learned the astride the horse technique of filling the simulator, so she can share that with you at the end of the workshop for how to get them really full and plump. Okay, so do you have everything you need here? Watch, or do we have a clock in this room? I guess not. Somebody do it. Oh, and
Somebody will bring out their smartphone.
Yeah.
Exactly. The other thing we can use is a sand timer for a minute. So that's a useful thing to use as well. So check off, do you have gloves?
We have gloves.
Okay.
We share gloves.
Share gloves. And do you have cloths?
So, what's the cord? These are the ties.
Okay, great. You can. We'll work through all of the equipment. I just wanted to make sure that everything was basically here. Do you use ties here in this facility, or do you use hemostats or clamps to kind
Peter, did they bring you hemostats? I
There
can't
was
see
some
this
size
baby sitting on a cold table, so I had to put that down.
Good for you. All right. You can even cover up your baby.
You know, again, from the district perspective, we tried to distribute hemostats on our essential equipment list, but it doesn't tend to stay in the facilities for use. So I think most of the folks are using ties still.
Okay, so a large part of of success with helping babies breathe is being prepared. So we want to spend some time talking about that, and here is the scenario where you can make a difference as a skilled attendant. So you and the mother and a helper are really going to be the team that works together around a delivery. So just being present at the time of birth and being prepared to help is fundamental. As Sherry pointed out, if there's no one there who is equipped and prepared, oftentimes babies are just laid aside. And it's so important that people be there at the moment of birth, because really being able to help immediately goes a long way to a better response from the baby. Babies are going to begin to breathe quicker. They're going to have a better long-term outcome if you're there right at the moment of birth and ready to go with your equipment and your skills. The other thing we can do for all babies is really to provide them a clean and safe environment for birth. Because what kills babies in this community, even if they breathe at birth, what are the problems that kill them in the first days of life?
They can get sick and get fevers, and then they die from some unknown fever.
They get fevers or infections, and so we need to create an environment that protects babies from infection, that's clean. What else kills babies in the first days of life?
Sometimes moms don't keep them warm enough, especially when they're little.
It's pretty hot here right now, but think about when you take a bath and you get out wet. It's easy to get chilled, and babies come out wet. So keeping them warm is really important. Because if babies get cold, Sherry's right, they can not feed well, and really can die just trying to be warm. And that brings up another important issue, making sure that babies begin early breastfeeding and exclusive breastfeeding. That prevents infection from contaminated water or formula that they might drink, and it gives them that energy that they need to continue and stay healthy. So we need to help babies who are not breathing at birth, but we also need to protect babies who are healthy to begin with in order to keep them healthy. So those are the two main goals. So how do we prepare for a birth? There are really 4 main steps. We need to identify a helper, and if you want to follow along as we're doing this, did any of you get a chance to review this learner's workbook before? No.
I've gotten to look at it.
You did? Okay. All right. If you have questions, please bring them up. We knew that many of you were not going to be able to review this before, so we'll go through the key points as we're talking here. If you want to make notes in your workbook, there's a place for notes, and you'll notice that the illustration here on each page is the same as the one on the flip chart up here. So this is the way you can make sure that you're following along if you want to use your learner workbook. So there are really 4 steps that we're going to go through in preparation for birth. First is identifying a helper and reviewing the emergency plan, then preparing the whole area for delivery, washing hands, our hands as the birth attendant and the hands of anybody who's helping, as well as the mother, and then preparing our area for ventilation and checking our equipment. So first let's talk about this person, the helper. Who is available to help at a delivery in this facility?
Break in for a second.
Sure.
Can we move these boxes? Just
Oh, sure.
have it there.
Yeah.
Do you want it on top of the boxes?
On the side is fine, it's just it was blocking my view.
Thank you, District Health.
Thank you.
So who serves as a helper here? Family? Is it mostly family members?
Yeah, especially at night, there's nobody. I mean,
How many people are on? How many birth attendants?
so at that particular facility, so there were 2 midwives, but they weren't there all the time.
We were there probably,
If they were there, was there always somebody else there, like the cleaner or?
there's always somebody there's always somebody at the facility, but it's not necessarily a skilled person.
And there's not necessarily 2 people,
It's not
especially.
necessarily 2 people, particularly at night.
So sometimes it may be a cleaner or somebody who's not a health.
That's doing the delivery, much less a helper at that particular facility. This is interim, are you saying?
I think there tends to be a nurse or some kind of a skilled person there all the time, but they may be attending to something else in that facility and not the
Other than
the person in labor.
So
It's
the
a
May.
full, because we're doing all,
Everything.
this health center is doing everything, yeah.
Sewing up
The
a
primary-
child's head who fell off a donkey.
Right.
Right.
So,
That's why you're doing it, that's what you're doing, good job.
So, with help, I mean, so are you saying there's usually 2 at this facility? There's always at least 2 people here at this health center? Or is there sometimes just one?
Sometimes.
Talking about humans, like bodies.
Sometimes there's just one at nighttime, one human.
So it may be that you really need to rely on a family member to help. So what kind of roles would a family member be able to do? If you need to help the baby breathe, what would you ask the family member to do to help you?
Actually, maybe run for help or
Yeah.
keep an eye on the mother.
Yeah, keeping an eye on the mother can be really important too. If you have to immediately switch your attention to the baby, it's going to be important for somebody to watch the mother for bleeding, to alert you if the placenta is delivering and she needs help. Maybe to just explain to her what's going on. So it's really important to talk about this with the mother and the family member and really ask them what they're comfortable doing, instruct them in what you want them to do. How about if you do have a skilled person with you? What would you ask them to do?
Can I just say, as a district person, we have a policy that the family members have to leave when the person's getting ready to have a baby.
No matter the
That does
gender.
happen.
No matter the gender of the family member.
Doesn't matter, we don't want them there, we don't want them to see what we're doing at the time to deliver.
It protects us.
But I don't know, are you guys doing that, or are you not?
Depends on if we like them or not.
Yeah.
Sometimes that happens. So do you know if that's policy in Uganda?
I don't know if it's policy in Uganda, but
But we've seen it.
I've seen it in several other countries.
It's interesting to hear that sometimes if you know that they're going to be useful, you invite them in anyway. And
Because he's not around.
I remember being in Vietnam, just a side note, but I remember this was in Vietnam, and I watched this woman get, really good care from her family members till she was fully dilated, and then they whisked her off like we used to do here in the 70s, 60s, back into another room, and they left her on a table all by herself, alone. And the baby, the baby came out. They put the baby into a metal basin, took the baby to a different room. So mother's in one room all by herself, baby's in another room all by herself. And she's got like 3 women that were, that were attending to her all through her labor, very nicely, that were being isolated from
So she would have gotten
either mom or
better
baby.
care at home
yeah.
as
And-
long as everything went fine. I'm sure.
And I've seen that in more than one place. I don't know, Laura, you probably have too.
And these are exactly the kind of discussions, it really wasn't a timeout at all here. I mean, these are the
On
kind
the
of
district persons.
these are the kind
You're
of
not really here.
discussions that really do come up and that we like to promote, and would encourage people to ask questions about that. Is it rational? Is that really the way you want to do it? And can we change that policy or change that practice for the health facility? And
At a master training level, though, I can see that could spawn some advocacy, but when you get down into a facility, you're not going to have the nurse and the midwife and the cleaner taking on the ministry to change the policy at the facility. I mean, it's a challenge.
it probably would have to be the facilitator who becomes aware of that. And
Probably maybe some good guidance though for people, that were preparing as master facilitators, master trainers, master facilitators to introduce these. That what are the policy type of issues that you might
Right, exactly. I mean, we deal with that definitely. Talking about uterotonic, for instance,
Yeah,
it's one
but-
very small.
Then you maybe, and how might you be able to advocate for that outside of the context of training?
I actually just lived this a few weeks ago in Ethiopia. We were there to do training around operational standards for a particular hospital. And we were talking around this issue specifically for labor support. And it made them very uncomfortable. And they kind of said, well, we can't do it because of risk of infection, and we can't do it because of overcrowding. And Sheena was the lead facilitator for this, and she just kind of said, well, let's talk about this for a minute. Let's kind of rationalize this out. And she brought up a slide that had all of the data to support improved outcomes around having a support person. And you could see kind of light bulbs going off. Now, that kind of change takes time.
Right.
But there was a kind of openness to it. And I think it's not staunch policy, but it's attitude and behavior and practice.
Yeah, for sure.
It was just interesting. I think there was a willingness, but a discomfort.
And it's pretty important, I think, for district health people to hear it from the providers that if we like them, we need their help, and we let them in. and
Because,
here's the
nobody else is
problem.
here.
Because nobody else is here, because you haven't staffed my health facility adequately.
Have you ever done this would you be willing to come to our district office and do this training for our policy people
Absolutely.
our local ministry office?
Absolutely.
I think a lot of people would like to hear, would help them to see what these issues are so that they can help to make sure that people have what they need.
And we really appreciate your being here and would welcome other people from the district office to even come out to the facilities and be trained there. But we can also come to the central district. If you do have two skilled people at a delivery, the second skilled person can really take over the management of the mother using the bleeding at birth protocols and can really stay with the mother and continue through the third stage of labor. Or if the baby is really needing extensive resuscitation, a second skilled person who's had experience with helping babies breathe could help you with the baby, with drying, with measuring a heart rate while you're providing ventilation. So there's definitely roles for a second skilled person if you're fortunate enough to have that. So part of the helper is identifying the helper's roles, but as you suggested, Sherry, another big part is communication. So let's talk about the emergency plan. What two elements are really important to an emergency plan?
We don't have emergency plans here. We just, pick up our cell phone if we think that we need to transfer a patient.
Okay, well you've identified a couple. So communication, so having a way to communicate beyond just the people who are at the delivery, and then transportation is another big.
Two people who own a truck in the village, so
Okay.
they can act as ambulances sometimes if they're around.
Is there?
Fuel.
Yeah, when there's fuel.
I was going to say, is there fuel? Is that something that is included in prenatal care to ask families if they have money for fuel or bring
come to us for, and not just stay at home. And in this village, yeah, there's just the two people with the truck, so everybody knows that that's the only transportation that's available, but we're mostly encouraging them to come in.
Yeah.
And sometimes we end up paying for the fuel ourselves.
Right. Okay. So there is a plan, but maybe there's a way that it could be started earlier when women are thinking about where their delivery is going to occur. If there's an emergency, they might need to have a couple dollars to be able to buy the fuel to get to the health center. And then, do most of your families have cell phones, or do you all have cell phones that you can use?
I have one.
You do?
Yeah.
Yeah. Great.
We all have bags and masks or uterotonic, and we all have
But you got cell phones. Well, that's really...
We have money, but we have cell phones.
It makes a huge difference. A midwife with a cell phone is in power.
I don't have electricity at home, but I charge my cell phone here at the clinic.
Here at the clinic. Good. Great.
And almost 100% of people in the district, our statistics show, have cell phone.
Yeah.
Our cell phone coverage is really high here.
Good. Who do you call? Where do you call for
The district
a
hospital.
patient who needs to be transported?
So who do they call? I wonder if they call the in charge at the facility if they want a transport.
You're supposed to call. Again, I can give you experience from having been at having. That's not Uganda. It's Tanzania. I was saying when being at Haydn, I can, which is close to Uganda.
Haydn is a very special case too.
Yeah, but from a referral facility, there was a radio. There was a radio and a radio operator, and all calls came in through there. Now the problem was the bottleneck was getting a provider to connect with the radio operator to make any kind of a decision. So in a timely way. Sometimes at the referral facility, there wasn't anybody there either.
Right.
Or they were busy doing something else, or running around the hospital, not available.
So it's important to have those numbers available in your phone so that you can call, and hopefully you can talk to a provider if you just need advice, or if you need to make a referral. It's important to let the receiving facility know that you're sending a patient in the truck before you set out, so that they're prepared to receive. So preparing the helper, explaining what his or her role is going to be, and then having an emergency plan for how you're going to communicate and how you're going to transport this mother and baby in case of an emergency.
Another thing we've been hearing in Uganda is that we call the referral facility, and they don't want to take the patient unless the patient has money. And it's a public hospital. It's not supposed to be that way, but that's we don't want to send them to a hospital and not have them let them in the door.
It's great that you're working on that.
We
are.
We arrested those health workers.
Excellent. Okay, moving right along. So, after we identify a helper and really prepare an emergency plan, it's important to prepare the area for delivery. So think about where your mothers are giving birth. What's important for you to do to make that area comfortable and safe for her?
Well, after every birth, the cleaner comes in and cleans it up, so it's clean for the next mother who comes in.
Good. So she has clean linens and a clean place to receive the baby and for the mother to be. So cleanliness, very important. What else how do you want your delivery area to be for the mom? Well lit. Right, because it's really going to be important to assess the mother and the baby, color, facial expression, whether there's movement of the chest, so you need to be able to see well. Do you have light in all of your delivery areas?
Well, we got some new plug-in torches,
Good.
so at night we can use those if we lose power, which is pretty often around here.
Great. Good. So it's important to have those available, especially at night. And then what else? What do mothers want in the place where they deliver here? Do they have specific wishes? Or people know about hand washing, but you actually have to do it for it to be.
Yeah, right.
Well, any opportunity to reinforce that, you know, the
Sure.
district thinks is a good idea.
Yep.
Really appreciate
So
that.
let's finish the last step of this, and I want you to actually neatly arrange your equipment in the way that you want to access it. So when we talk about preparing an area of elevation, where's that actually going to be in your delivery area? Do you have a little corner, or will it be only on the mom's abdomen that you have to work?
I see things on the bed, and I do see table areas that could be used, but I think people will.
Usually,
I'm sorry?
most people just put it on the bed.
If you do have a table, it's wonderful to have a table by the side of the mother, or in an area of the room that's free of drafts and that's well lighted. Again, you want the table to be pretty solid, so I wouldn't want to put a baby on this table
Yeah.
because it's pretty wobbly. But make sure the surface is solid like you have, and arrange your table so that the head of the baby can be closest to where you're standing. So if you're going to be standing here at the side of the table, we'll arrange it so that the head of the baby will be there. And then you're going to take off your ties and have them ready to go.
Or
Your scalpel.
Your scalpel.
Okay. Good. Now another part of preparing your equipment is actually checking to make sure that your bag and mask are working. Great. So Sherry's showing us how to do that. So what are you looking for, Sherry?
that there's a seal, and that
How do you know that?
because you can feel it, but also if you're pushing too hard, you can. I'm assuming that's the release valve.
Right, so Sherry was checking that this mask actually made a seal with her hand, and that she felt some resistance, and then she knew there was resistance by activating this pop-off, so that little boop sound is air escaping from that valve, and that prevents the baby's lungs from being overinflated. What else is, well, that's out. Another important piece is that fish lip valve inside, so
Oh, cool.
yeah, watch that move.
That's cool.
There you go.
It's like, yeah.
Can you see it from the other side? If you take your mask
You
out,
can see
you
it from
can,
both sides, actually.
can you? Good. You can really see it if you take the mask out and look right into it. It's like fish lips opening. And that's really important in these bags that get sterilized over and over again, because the pop-off valve can activate fine, but the air isn't actually getting to the patient unless
Because it
that
seals
valve
shut.
opens. Yeah, yeah. So 2 important things to check to make sure that your bag is working. Okay. Anybody have any questions? We'll talk about cleaning the bag at the end of the course, and cleaning all the equipment like you asked for. So let's go to page 7. Laura, you may want to trade books. I don't know if your book is going to be different from Peter's.
Do you mind, Peter?
You do give a book to each learner, not
Yes.
a pair, not one to the pair.
Exactly.
Okay.
So they take this home, and actually the ideal is that although you use one simulator for a pair during the workshop, everybody goes home. So we have another
Everybody goes home with everything. With one.
duplicates.
Okay.
Yeah, that's the ideal. So on page 7 there are a couple check yourself questions, and these are mainly to sort of stimulate your thinking about other questions you may have, but also as a check of what we've been talking about. So who wants to take the first one? Go ahead.
When should a skilled person be present at a birth? I think at every birth.
Right, as we've talked about, being prepared for the unexpected. And how about the second one?
When should you wash your hands? Before and after caring for a mother or a baby.
Great. Good. So we are here on the action plan with preparation for birth. And you see this is right up top. It says prepare for birth. And that asterisk takes us down to this equipment list here. So we're beginning the action plan. And as we go through this, we're going to do a series of exercises that relate to the action plan. So if you turn to the next page in your learner workbook, this is the exercise for preparation for birth. So we've learned these 4 steps in preparing for a birth, and now we want to put those together. And I'd like for you to work in pairs during this exercise. So in this case, one of you is going to be the birth attendant, and the other person will take the role of the helper. So I'd like for you to work through each of these 4 steps. First, with one of you as the birth attendant, the other as the helper, and then switch the roles so that you can have the experience of being both birth attendant and helper. So begin by introducing yourself to the mother, who's not present here, but we need to acknowledge her presence, and then you can just work through this checklist on page 9. Complete each of those steps in your pair, and then we'll come back together for questions.
Do you want to be the birth attendant? Sure. Okay.
So, welcome, Natalie. And I see that you have someone with you today who's a missus.
So I'm her sister.
Okay,
So I'm going to be the helper because we don't have anybody else at our house.
that's great. I'm so happy to have you here and helping. And I'm just going to start off with making sure that we all have clean hands before we do anything else. So we're all going to wash our hands. I'll pass that. And Natalie, would you prefer to have windows open or closed? We do have a curtain we can use if you prefer for privacy. And our ambulance driver is gone in another town. Do you have anyone you know with a vehicle in case something goes wrong?
I don't think do we have that requirement stuff that I would call it for me too.
Yeah, I'm actually going to just call him now and let him know there's a hunger happening in case anything goes wrong. You know that you should be on standby.
Maybe we should just maybe come from 2 things.
Yeah.
So we have everything ready?
Do you remember the 2 ways we know that that's what the next one?
Oh, please remind me.
So Suzanne, how much coaching are you typically doing during this phase? Are you more watching to see what people are doing?
Oh, yeah,
So
Second
we're
one.
watching, and we count a lot on people to autocorrect. So this group just said, remind me. And that's exactly what we want to go on. So you are absolutely demonstrating this. And we're watching for people to get stuck or
What do I do?
steps. Yeah.
I think we're ready. So we have Natalie you get it to pop off.
So this is why they need the combo ones, because you could get a better skin.
Yeah, you probably have to kind of hold it.
Squeeze it
And we'll learn that putting pressure down on top of the mask is really important to get a seal, and you pretty much have to do the same thing when you're
It's
testing.
louder
it.
than
Yeah. Are you having to switch roles?
Oh, we're supposed to switch.
Oh, okay.
So, what's prepare an area for ventilation?
Prepare, so to have a place where once the baby's born, so this is where we're gonna put the baby, if we need to.
ventilation. Got it.
Right, so yeah, bag and mask, so basically, okay, so if the baby comes out, if the baby's fine, we're not gonna put it on the breast. It stays in the mother's arms, covered up.
But it's not where we can resuscitate if we need to.
It's kind of confusing too, so we...
Because we talked about drafts and windows, and then
Right,
I was like,
the
oh,
area, and the area for delivery,
Yeah, right.
and the area for ventilation,
Got
so
it.
you hone in on that.
okay.
So we have two sides
But
to
that's
masks.
a really good point to bring out.
Are you using my help today?
Yeah, I'm a cousin.
Okay, so let's draw the curtains, so we'll close them, so she has some privacy, if you'd like that.
Are you
That's
recommending
nice.
as part of the
Let's go ahead and wash
HPV
your
that
hands. So
that
this is some alcohol rub, I don't know if you've ever seen it.
every
No.
birth
What?
has an area prepared for immediate
Go ahead, rub it. It has
ventilation,
alcohol in it, it kills the
regardless
germs.
of. Okay, so not like here where you have your equipment, you get it out if you needed it.
Okay, this is where we're gonna put the baby, the baby's gonna
have
be
an
here.
area set up.
And we're gonna make sure
Okay.
all of our rooms are ready.
Do you not
We're
feel
ready to go.
risk?
Not for low risk. We tend to have things immediately available in a kit
Yeah.
that can be grabbed, and
Yeah.
it doesn't get opened up every time by the nursing staff.
You're talking
Let's
about
talk about-
locally?
Yeah.
Yeah.
Let's talk about that. We'll come back to group discussion, but
It's more of a curiosity.
district health representative, that's a good question.
Okay.
We're afraid we get these things out all the time, we're gonna walk away.
Yeah,
So,
yeah.
Have you all practiced?
We're all set.
Time to
We're ready.
practice, good, okay. There was a really important question brought up by the district health officer. So do you prepare this equipment every time? And what would your practice be? What do you do now? Are you going to do anything different after this course?
If these are new in facilities, especially when you give them to individuals and they feel like they're theirs, I would think that the tendency would be, well, this is mine and I'll take it back and forth with me to make sure I have it, and so of course it may get forgotten, so I'm not sure how you address that, we can talk about it later, but especially if this is new, anything new is a coveted kind of, it'll end up locked up.
It'll be in the lodge cabinet. I mean, the general child health district head in a nearby town.
Yeah, glad to be
Yeah.
And what we find at the district level is people, lock them up because they're afraid when we come to inspect that they're not gonna be there and then they're gonna get in trouble.
So we make sure when we know they're coming that we bring them out. But, before every delivery, we will have, a blanket for the baby, and we'll have scissors and ties and,
And gloves if they're.
and gloves.
If they're.
Yeah, if we're not out of gloves.
So you're saying this might not be available?
Is the idea that these are issued to participants rather than facilities for practice purposes?
So they really can be used for both purposes, and what we're encouraging is that these actually a simulator and a set of equipment actually stay set up in the facility, and it can be in an office or in a locker room area that's not public, where
So there'll be additional ones that are for
Yes.
facility.
Yeah,
That's-
yeah. So we're not just depending on people who are trained to equip. The district should be equipping the health facility as well. Part of the logic is that these are relatively low cost, and they are meant to be available. So they can be available, for example, in the bag that's in a charge station or somewhere that's attended and has has some level of security, but not the level of security of the locked glass cabinet where you can see it, but you can't get to it without breaking the glass. And that's actually one of the group discussion questions. How will you have, number 5 is how will you have clean working equipment and supplies ready for use at every birth? Because this comes up everywhere.
Right.
And people need to decide their own system. So what do you think would work in this facility? Where could this equipment be kept? The difficulty is if you have to run, go get something when a baby is not breathing, you're losing critical seconds, and we really are talking about seconds. So where would you have this?
Seems like we need an area where we, since we'll just have these 4 at our facility, we'll have an area in the delivery room where we keep all 4 of them. Because if we have a birth and we use it, and then we have another birth and we use another one, we can grab a clean one out of that same spot. But, we could have it in a cabinet where we keep, our other instruments next to it if we've got one in the drawer.
That might work well. And people know that that's where they live, and everybody's responsible for
And
keeping
everybody
them
has
there.
access.
And
So instead
everybody
of taking them
has
home,
access.
maybe we'll put them there if everybody agrees.
Are they locked in a drawer with a lock?
No, so you knew, that's right. So yeah, we'll show you during orientation, but we have a drawer where we keep all of our clean equipment once it's sterilized, and then we pull it out and grab what we need for each delivery when we remember to do it before delivery. Sometimes we don't, but we should.
Because I was wondering if something were to happen in the middle of the night and I'm the only one, would I need a key and
Right.
all those things?
And not for these.
Okay.
We've talked about a lot of issues around not having clean towels necessarily, or hand wipes. Do you have clean water always here? Is there always running water
So
available?
I don't know about that facility, but we would fill up a large drum. You've probably seen them with a little spigot at the bottom and the bowl underneath to catch the water when we wash our hands.
Good, so somebody pours.
Well, so yeah, that's one way, but we've got the big canister over there that's, I don't know how many gallons those are.
We-
5 gallon
With a spigot.
filled with water with a spigot, and
Okay.
it's in the room. We bring it
Okay.
every day.
Are there any other barriers that you see to preparing for a birth here? Or any questions that you have, that other gaps that you see?
I think as a nursing student, the problem of access is forefront in my mind. How am I going to get what I need?
What you need.
So, and students are so practical thinkers, so that's sort of why I'm gravitating towards it. In my mind, am I going to know where it is where all this stuff is?
Yeah, and what if it's not there? Then what do you do? What's your plan B?
Right.
Would it be to go to the person in charge, or who?
Yeah, that would be, but if you're the only one there, so hopefully you'll get a good enough orientation that you'll know where things are.
Sherry's going to teach you the secrets. Where they hide stuff. Good.
We'll let you know, where the skeletons lie.
All right. So that's the first preparation for birth. I'd love to take you through another set. We can do routine care and maybe quickly, and then do at least the
So you teach,
ventilation.
the mask.
Yeah.
Absolutely, let's do that.
But the group discussion is where we kind of come back together.
We have an hour and 20 minutes just to,
Okay.
just
We
to
could
give
do-
you, yeah.
And this is pretty typical of a Helping Babies Breathe course, that we spend a lot of time at the front encouraging people to talk and bringing out a lot of policy issues in the beginning. We want to let people know that those are on the table, and that that's part of really getting the full benefit out of this course, is that they need to question things that they may have always done, but there's some discomfort with, and they need to bring up issues that are problematic. So that's the purpose of the group discussion, is really localization and kind of personalization of the program to the facility where it's being taught. And also the purpose of the check yourself questions is not just to check the knowledge, but really to bring out other questions. And it's amazing. It's not really as good in a group like this that's very sophisticated, because these questions look very simple, but when you actually are dealing with frontline providers, these questions open up amazing experiences that they've had that you kind of don't imagine until you're there. Okay.
So are these ours? When we writing them?
For real, she's asking.
If you, yeah,
As me.
yeah,
Okay.
yeah, certainly. I think that.
It's Laura Fitzgerald,
Yeah.
not Laura.
We want to send you home.
Well, Laura's role with the maternal health advisor MCHIP program is good, good introduction to this. I don't know if anyone
Absolutely.
has this level of
Yeah.
So Susan, are we
understanding.
going to go from here to, so let's keep going in order
Sure.
for how you handle the, the
If you
next
just want to
step.
say this is where we'll fast forward.
Yeah, and then
fast-
when you want to fast forward, say, okay, we're going to,
Okay.
whatever, that's, so then we can go with the flow.
Okay, all right. So, we're going to now go on after the baby is born. And here's our first step up here. So this icon signifies birth. And what's the first thing that we're going to do for all babies after they're born? Dry them thoroughly. Okay. So Sherry, maybe you want to demonstrate your technique for
Drying the
drying a
baby.
baby thoroughly.
So do you have them simulate on the table? Or because most births, you've just done this for the mother. So how do you do that in the training? What
You can do it either way. Sometimes I noticed you had a pad over here, and sometimes we use that as the mother. So it kind of depends on people's
Okay.
comfort.
So-
you can designate. We may use a pillow or
As
a
Leah
folded
said, mother.
or you can be the mother.
But I have a feeling when you're doing the training, people are doing this on the table more than having a model hold it.
It kind of depends as the group loosens up.
What they wanna do.
often will.
I would think, going back to a training perspective, breaking my position, but I think this would be a great opportunity to
Reinforce the
reinforce
baby
what you
gets
think is
delivered.
best practice
Yeah. Right.
and try to encourage
Yeah.
them.
Yeah.
Right.
Maybe watch to see what they're doing normal,
Okay.
but then direct them
Okay, so then so what I would
getting
do.
skin to skin.
So you're going to make this the mother?
No, she wants
You
to
want
do
to
it.
do
So
it.
what
Okay.
I would do is, when the birth is imminent. Okay, Natalie, your baby's coming, and I would put a clean cloth down, and then I would. It's a girl! Congratulations! Thank you. And then I would take another blanket or this one, and be drying the baby. And drying. Let's get your baby dry. Let's see if it's crying. And then the baby's dry. Okay, I'm going to take this wet blanket off. Here, right next to you, I'm going to put a dry one right on. Keep the baby warm and dry. There you go. Is baby crying?
Yeah, because the mom should be draped.
All right, and so let's put the hat on.
So the mom would be draped over the lower part, right?
And then I guess
we're
it's
skin to skin right now, right?
yeah. So
Yeah.
I guess it's just individual technique, but I certainly don't ever rip the mother's gown up to put the baby,
Put the baby on the skin.
necessarily right up front because she's at a very sensitive time as she's delivering. But anyway, so I would put something down on top of her gown, just get the baby going and drying, and so some of that's just technique, So I don't know if you have something very specific as to how you.
But one thing that I really noticed about your technique was that you were rubbing
Right,
the
so,
baby,
yeah.
and that's really the key piece to this. So Why don't you practice that?
So 2 points. One for drying and getting the wet off, and the other is stimulating.
It provides stimulation, exactly. So
Okay.
this is an important piece that all babies
So
need
what
to
now?
preserve their body temperature and to stimulate them.
What have you seen people doing when you're out in the field in terms of rubbing, as opposed to rubbing?
You know, it's interesting, but especially pediatricians. I think midwives are better dryers than pediatricians are, but pediatricians dab. So you don't want to be a dabber.
Be a rubber, not a dabber.
You want to be a rubber. Yeah.
You know, I think it's also important to maybe mention to participants if they're going to use this, to communicate that to the mom. When I first
What did you say?
transitioned
I'm sorry.
from practicing in the States to I went to hospital in Tanzania, and I was used to doing this. I did this to the first mother I delivered, and she was like, why are you giving me this child? I don't want this.
Really?
And
You see
and
that in the
nurses
US.
also.
Yeah, I mean, you can say it definitely depends on the.
So she needs to be ready.
Really important. So in India, we've encountered a little bit of resistance with putting a slimy baby on mom's chest also.
That's a really good point.
Yeah. So that
But Laura,
comes
did you
up
find
later.
that preparing mothers and telling them why you were doing it, that they respond, were they
I think
more
just
accepting,
giving them
or?
the option to say, do you want that? You know, we do this, it helps with the baby. Some moms don't want it. And it wasn't, like at that time, it was definitely not practice, and the other nurses were not supportive. So I didn't
Just
I
the
didn't
skin to
really
skin
push
part,
it.
was that what wasn't supported?
Yeah.
And
Yeah.
would you explain this is to keep them warm?
I just wonder
Yeah,
if it
I
changes,
did.
again, I'm breaking role to be a little thoughtful here, but I'm just wondering if this is such a huge issue in terms of keeping babies warm, keeping them stimulated, and initiating, early breastfeeding and bonding, all these things that are issues. If it's something we should be more aggressive about and
Yeah.
Maybe even antenatal
preparing
care.
people ahead of time, making,
Right.
getting the staff and the culture supportive of it.
That's a good
Before
point.
they're labor.
You know, so my
Not a time
oldest
to
child
discuss.
is 28, and when he was delivered on my belly, I was totally unprepared. I'd gone to a midwife, but I was unprepared for this, like, slimy, he was 4.5 pounds, he was quite tiny, splatted on my belly, and I was like, kind of like, and like, oh, and I just remember, and I can still kind of see myself like this, and I'm from the U.S. And so it's just, we don't, but I certainly wasn't going to say, ooh, get it off me, because that's like socially not appropriate to say that.
That's an automatic social services referral.
Yeah, exactly. So my son was just here last week. He'd die laughing at that story. But I was really actually
It's a
quite
shock,
happy when
yeah.
they took him off because he was so small and it was a surprise and everybody got really quiet and so he got taken away pretty quickly. Take it to it wasn't a NICU, it was a small hospital. But so even, we think that we're midwives and so it's like, oh yeah, but it is something that's worth, if it's that important as Peter said, for the health of a baby.
And that's a really important point. We didn't talk about it explicitly in our preparation for birth, but while you're explaining to your helper what you want to do, be sure and include the mom in that too, because all of this may be very different, and as we're talking here, it's going to be great to be able to incorporate this in your prenatal care and your preparation, not only having money for gas, but kind of knowing what's going to be done for the baby. You can actually use this baby to show moms in your prenatal visits. If you're traveling around, you could take a baby with you and show the mom how it's going to work after delivery and show her what you can do to help her baby breathe.
It was interesting, Susan, Sherry and I shared our materials and the mamaNatalie simulator to one of our very senior technical folks from the Kenya office, and her initial reaction was, we can use this in our young mothers clubs where we're preparing folks for, for parenting and for, birth. And I'm wondering if if all of these things we're developing, if we could be developing demand side tools and interventions at the same time that we're fair to them.
I really think so. The Women's Federation in China is using these to kind of do consciousness raising. But if you think about it, if a mom has never seen anything like
It's
this,
frightening.
she might think that you were suffocating.
Yeah.
Or
Poisoning,
or,
whatever.
or,
Something
or
scary.
pulling the spirit out of a
Right.
child. I mean,
Right.
anything like that for sure.
So it could be really important to take away the fear of what's being done, but also plant in the mom's mind that you have something to offer her that's special, that's life-saving, if she makes sure that she has an attendant delivery. That's
So, Susan, when you do HPV training, do you encourage, because I actually think as an advocacy, you know, as a method of advocacy to say, we would like to train you in, you know, for the normal birth where your partner is actually, you deliver this baby up to the, you know, up to the mother's chest as you would, or are you typically reaching pediatricians who wouldn't be delivering babies? I mean, you're reaching the gamut.
We're really trying to reach midwives primarily.
Because that could be the first step in having that discussion of what we all just had right here. Oh, the mothers wouldn't be okay with that, or you know.
It's lots of levels. So we have to teach pediatricians because if we don't, they're going to block
Yeah, sure,
that
absolutely.
practice because they say we have to have the baby.
But they have delivered a baby or two usually in developing countries.
Yeah.
So I mean, they can kind of remember how to, at least the hand motion.
That's right.
But that's not their hand motion. Their hand motion is more they deliver to, you know. I think doctors in developing countries are not trained to deliver a baby on the chest. I don't know, Peter.
It's really interesting to hear you talk about that hand motion because it really
Because that's what we do.
is different. And you're right, a pediatric hand motion is this, and you sling over your arm and then take it.
And with one hand to clamp and cut the cord. And,
Yeah.
okay. All right. Excellent.
Good. So just to summarize the important points of drying, that we're going to really rub this baby with a pretty vigorous motion to remove the moisture and to provide stimulation. And we want to really focus on the big surface areas. So we want to get the trunk. Remember that the head is a huge amount of the baby's surface area, so it's important to try to dry the head, get the extremities, and then the other important point is to remove this wet cloth, as Sherry did, and then the baby goes skin to skin with the mom and gets covered with a second cloth, and we also can cover the head, so if you want to put a hat on. It's almost impossible to get hair completely dry right after birth, so the baby continues to lose heat from evaporation of that wet hair. So if we just cover it up, that prevents the heat loss there.
Do you in trainings talk about the rubbing as unnecessary stimulation? Because you see a lot of smacking and flicking.
That's an excellent question.
Yeah.
Yeah.
Good. So what is a safe practice?
Well, we flick the heels of the baby's feet.
You do, okay. And we'll be talking about that as specific stimulation to breathe. Probably the most effective stimulation is rubbing the back. So when we do this rub over a large surface area of the trunk, that's pretty intense stimulation for a baby. And that's probably the best and safest stimulation to breathe. In some parts of the world, it's acceptable to do a foot flick. In Switzerland, it's child abuse. So it's not in this program because this was,
I was being my character when I said that.
yeah.
Yeah. I just see some crazy stuff.
Well, is that one of the things is that one of the things that you would recommend, but you don't because it's not considered child abuse?
So Peter just did an RP. I think it's still still
I
there.
thought, I thought
it's in
from
our
last
paper.
time I was there, so it hasn't been pulled out of that, and you won't,
No.
because.
WHO doesn't approve NRP.
Right.
But to harmonize this
Right.
with WHO, we had to take the foot flick out. It was originally in there. So that is considered a harmful practice.
We know that from our.
Even though it's what made my best friend's first baby breathe, was a foot flick with conviction.
So what if the government, what if we're in Uganda and the ministry says,
This is what we teach.
We have that in our curriculum for our healthcare workers.
Good point.
This is what we want people trained to do.
So regional variation certainly enters into this, and if a local government wants to print up a sheet of recommendations or kind of
Addendum, kind of local
notes
addendum.
that they want to put in, as long as that's been ratified by their health body, it can't be just the local facilitator or whoever who comes up with it.
Part of their basic package of health services.
Yeah. Yeah.
Okay.
So we ask that the action plan not be modified, but certainly you can have an insert in this that
Okay.
addresses things like that. So have you seen other things that have been done to stimulate babies?
I mean, I can see the slapping and the flicking, but I've heard of turning babies upside down, pouring water and alcohol.
Pouring alcohol on where? Just on their bodies?
I don't know how did Blanchard tell me that. Blanchard.
Well, so what would happen if you poured alcohol on a baby? When
Make
it
it really cold.
really
Yeah.
cold, it would make that baby an
About
icicle.
Evaporation.
It would be interesting to pose some of these questions to our experienced, our really sage M&H staff, the Barbara Dellers, the Sheena Currys.
What
the
have they
people-
seen?
Yeah, the Tricia Gomez. What have you seen out in the field?
Barbara has some amazing,
Because Barbara has some
frightening
amazing
stories.
stories.
And what we do before we do a provider course is get the local instructors, the local facilitators or potential facilitators together. Usually there are some people who've been through helping babies breathe, and we actually go through each of these lessons and say what are the
Are there flashpoints here?
flashpoints?
Probably.
That's a
Yeah.
great word for them.
Yeah.
So that's the
Yeah.
preparation for putting on a course is knowing what the real local
Part of
issues
master
are.
trainer development.
That's right, yeah,
Yeah.
for sure. Okay.
Good. So, Tara, what do you notice is going on right after birth as well as drying thoroughly?
We have to assess if the baby is crying or not.
Right, and even before that, there's a little line there.
Oh, the meconium? Is that what you're
Right.
referring to?
Right. So it says if meconium in the fluid, clear the airway. And actually, in our next edition, we're going to say if meconium and the baby's not crying, clear the airway.
What they say in NRP.
To be. So WHO just changed
It's changing, yeah.
their recommendations to decrease the emphasis on suctioning. But it's important to consider this right after birth. So if the baby's crying and vigorous, they're going to handle their secretions fine. They're going to cough up anything that is in their airway. But
Susan, it was interesting, just a aside, when I was doing the NRP, how resistant the team members were to that
To
change.
not suctioning
To
for.
not suctioning. It
I mean,
was
and so I mean, especially some of the old.
just so
school,
habituated to it.
If the baby is crying and screaming, but it had thick meconium, by God, we are going to scope that kid and give him a vasovagal reaction. So not only they stop breathing, the heart rate dies. Yeah.
Yeah,
So,
Yeah.
so no, you're absolutely right, and it's sometimes more difficult to reprogram people
Oh,
who've
sure.
been trained
Yeah.
than it is to learn it
Yep.
I think people don't want
the
to
current
change.
way.
Because it's like by changing, they're almost admitting they've been doing it wrong this whole time, and nobody wants to think that about themselves. So you have to try to frame it like you weren't wrong before, but now this is just better.
Well, and yeah, there are good phrases you
Right.
can use for that.
And this was a change that was actually made on evidence. So what happens when you suction a baby
Vigorously.
vigorously? Yeah. So even with our little penguin, if you get the tip down in the throat, that can trigger that vasovagal response. And what happens to your heart rate? Exactly. So heart rate can go down. It can make babies gasp, but then hold their breath.
Yeah.
And that's not what you want at that particular moment. So do you all know what happens when meconium gets in the lungs?
Meconium aspiration syndrome. Yeah.
Infection, it can carry infection with it, certainly. It really doesn't belong in the lungs. So it sets up a lot of inflammation, especially if the baby has had some low blood flow or low oxygen circumstances. So if the baby is not vigorous, that means they probably have had some low oxygen, and then it's more important to get the meconium out. So we'll talk about how to suction that out if the baby's not vigorous as we go down the golden minute. But that's the moment we would do it if there's meconium in the fluid and the baby is not crying. Okay, we could go through the check yourself questions if anybody has. On page 10.
The baby's not dead, but she is placed on a cloth beside him whatever happens. She can become cold because she's wet.
Great.
And then what can happen when the baby inhales meconium? You can have breathing problems.
Right out. Absolutely.
So is that a question you're thinking about changing then? Just because if there is meconium but the baby's crying,
Right.
you don't want to, meconium will cause breathing problems, therefore I have to suction it out, even if the baby's crying?
Actually,
Or what can happen when a baby inhales meconium
it was more.
and they're not breathing, or,
I think it was more just to check in that people knew that meconium was a substance that causes problems.
right?
Do you think that question is misleading?
Well, I think when you change that, it's not that it's misleading so much, but it's, again, these are also for drawing out emphasis too. Like,
Right.
these are the important things.
Right.
But I think it could easily, when you change that, you can still have it centered on meconium, but it's something for later. You said you were talking about another version. Are you making that change pretty quickly?
We're revising it in 2015. So now we've issued FAQs that are on the website that just say you need to change the emphasis here and really emphasize that this is for the baby who's not crying here.
That's
So
easy enough
actually,
in training.
I've made a note in my flip chart here. So this is my annotated flip chart.
It's worth its weight in gold, probably.
That I travel with.
Yeah.
So I add all those things, but you're absolutely right. We have modified that. Okay, so let's move on. We've actually seen that we may do different things for the baby who is not crying and the baby who's crying. So it's important to differentiate between those two. Crying really means that a baby's breathing well right after birth. And we can actually make these babies cry, and we're going to be doing this, so I want all of you to practice with your babies how we would make them cry. Now, let's see. Oh, so now look what's going on here. See, your baby's chest isn't moving. So,
Yeah, I tried to fix it earlier.
Right.
I'm not sure.
so this is important as you're using your simulator. Sometimes these little plastic tubes get kinked. Right. So now,
That's
look.
better.
Great. So now your baby's chest is moving well. And then to make it cry, we're going to squeeze ball at the same time. So you can all practice. So good chest ball movement.
So if you want to take a break and, come back later, do.
So you'll hone in on that particular step. And the key here is to do 2 ties. So we're going to put one about 2 finger breadths from the skin. And you can use whatever. Do you have a special knot that you use? Do you double knot usually?
I don't know what they use, but yeah,
Yeah.
throw some sort of hand tie.
And then the second tie can go
The same distance.
5 finger breadths or the same distance. Right.
5 times 2.
And then you want to cut between, right? And you can actually pull this cord apart, right?
Ta-da.
Oh, wow. Yeah, five from the skin. Yeah.
So something that came from Patricia and from the field, and I guess our training anywhere, but especially HIV prevalent countries, is to protect the provider. And yes, we tell them wear goggles, but they don't necessarily have that protection.
Mm-hmm.
To use a sterile piece of cloth to cover
I like
a
that.
gauze,
Yeah.
so they can still see what they're doing, but it doesn't get a splash in the face. And
Mhm.
so that's how I looked for it in our training materials, Peter, and couldn't find it. But this is something
It's probably just something that's
everybody
developed.
teaches.
And the other thing we teach, what I teach residents is to put on this first tie, and then it's harder to reattach, to reestablish fetal circulation.
Yeah.
Isn't it?
This one is the one that goes in. There we go.
These are all different.
So this
Yeah.
one has on one end it's
Let's not-
firm and one end it's soft, and
And
so
I-
I put the firm in.
I think this may be the hybrid display kit again, because they're different models.
Oh, that's what we have, the one that
attachments.
kind of snaps off.
Yeah, well, that's what
And they
they
put,
should
yeah.
have. Anyway, so you put on the first
You
tie,
guys do a good job.
and then
Milk it a little bit.
milk this a little bit, and then put on the second tie. And then you essentially express the blood.
Then you don't have
This
that yet.
segment of cord, and it
Yeah.
decreases the
Splash.
splash, so you don't have
I've
that.
personally learned the value of doing that.
Yeah, I think we all.
Had a blood
Jeez.
splash to your face, have you? Yeah.
And I'm always grateful I wear glasses. Let's do these questions, because it brings up some interesting ones on page 13. Let's take the first
You
one.
notice bleeding from the umbilical cord even though a tie is in place. What should you do? I'm guessing place another tie between the first one and the baby's skin. Well, we didn't talk about it.
Right. And some countries actually place 2 ties just as a routine. Yeah. And then the next question.
What actions help prevent infection of the umbilical cord? Good hand washing, wearing clean gloves, and cutting with sterile scissors.
Great.
That was another thing that came up. We're training to wear 2 pairs of gloves at delivery, so they have a clean one to do that. Do you do the same here?
We didn't specifically recommend it, but it often does come out in discussion around this question about what the local practice is. So we didn't feel like it was really our purview to talk about the delivery part, but WHO says change gloves, and it's like, oh my gosh,
The time.
that takes a long time.
But ripping off and you got perfectly clean gloves.
Ripping off makes a whole lot of sense. Yeah. So I think that's what we usually recommend here. How about other substances that are applied to the cord?
Sheep dung, very
Sheep
popular.
dung. Cheap, easy, and available.
I don't know who came up with that. Whoever thought that was a good idea.
Is that really used in Uganda?
I don't know about Uganda. That's more of what, an Indian thing?
And Egypt, it was the cause of the tetanus epidemic in Egypt. I know.
Heard of it in Ethiopia.
And in Ethiopia, I think it's.
Ethiopia.
Does anybody know the cultural significance behind it? Anybody? Do you have any idea they have some rationale.
Yeah, there's got to be some
I think it
anthropological reason.
drives the cord is the logic, and there usually is some logic behind
Right.
traditional
Oh, yeah.
practices. So it's important to try to get to that logic and what people really think about it.
And
And
most
then,
mono-diabetics walk in warm cow pies, and my thing was, I think it increases circulation in diabetic feet.
Because they're warm.
Yeah.
Mhm.
And then-
it feels good.
And then it's sort of
That's why I do it.
and then there's sort of this transfer of, then that's like a helpful substance, and it gets used
Use
for
dogs,
other things
but-
that you want to be healthy.
You know, that's
Yeah.
actually brilliant,
Yeah.
and that's probably, I bet
Yeah.
that is, yeah.
yeah. Okay, I'd like for you to work in pairs again, as we did before, with one of you being, you can either do it as one person being the mother and the other person being the birth attendant. In this case, the mother would need to supply the actions of the baby, or if you want the other person to be the helper here. So we'll go through this checklist on page 15, and just to refresh, we're working through the left side of the action plan here, the routine care.
Okay. So we already did earlier where we had the clean blanket delivered to your chest, dried vigorously.
You can actually do that.
Yeah.
Yeah, because this is where we want to put everything together.
Yeah, so deliver my baby, man.
That's right.
I've got all the devices.
Okay.
Oh, the head's out. We've got a crying baby.
Yay!
All right.
I'm gonna put it up on your chest.
All right.
Okay, you ready?
Yep.
Well, not exactly.
We're ready for it.
I think I just had the baby.
Okay, you just have a baby.
I forgot.
Okay, this is over here. Congratulations. Scrubs. Dry.
I love that.
Yeah.
Take a while.
Yeah.
We're just gonna wrap him in a clean
Dealing with
towel and just a dirty one.
Keep warm. Check baby.
Make sure that he stays warm.
Yeah.
Let me just take this wet one off. Just like that. We're gonna get him a hot. Make sure he stays warm. And see that heavy cry.
I'm gonna turn it around because it's crimping. Here's my phone.
No,
There
it's
you go.
I bet it doesn't work. Why not?
So, I think we have no meconium.
Okay, there we go. Yeah, that's came to pretty easily.
We're going to do the couple of so I'm going to get an extra bolus of blood here.
It's time first.
And so you can see your face, get to know you a little bit. And I'm just going to sneak around from this side.
Okay.
Alright.
I think it's been.
And we're just gonna tie and clamp the cord, okay? So try and keep him warm throughout this. Keep his little feet warm. Can you do
Oh,
that?
sorry, I just bumped into the thing. I need a bigger blanket if we're gonna do the head wrap. But I like that.
Yeah.
And do you have family here? Anyone who'd like to see a baby?
No, I'm a single mom.
Okay.
Usually.
They're everywhere.
Yes, my sister and my neighbor will help me.
You look
Okay.
much more comfortable with this baby.
I know, I know it's tempting to want to give your baby a bath,
Oh, that's what they were supposed to
but
do.
your
Good job.
baby has trouble keeping itself warm on its own now that it's no longer inside of you, so we recommend that you wait at least a
Sure,
day
would you demonstrate
before
the double
we
blood
bathe the
thing?
baby, but you're going to be here with us for that long.
Okay.
And now,
Okay.
I'm gonna
How long
take
can I
So
stay here?
delivering your baby.
you can stay here for 24 hours.
Does double gloving work with looks like this?
Yeah, I mean, it's what
Yeah.
we have, you know.
So now we're probably going to be delivering this pretty soon.
Wash
But-
this. Well, it helps if they fit.
Yeah.
I know my hands
Yeah,
are
you do.
falling off.
What
my
size do you work with?
Even the
Is there
I
one?
know, and then I'm like
It's
tripping
hard to
over
get
the
5.5.
fingertips.
You were 5.5.
5.5, wow.
Those are really hard to
It's hard to find.
Yeah, they don't. Once you're on medical staff,
So
though,
while
you're
we're
really.
hanging out waiting for
You reach a certain
Yes, I can.
Sure, people prefer you for college.
My
exams.
tiny.
Exactly.
And the mouth is moving.
That means that.
Yeah.
Did you remember?
I did. I didn't know before.
That was my fault.
Let's do the second
Okay.
scenario with meconium too.
Oh, okay.
Okay, thank you.
Do you teach suctioning at the perineum with thick meconium?
So it's in the materials that is an option because the Indians insisted that we put it in. And now WHO is asking that not be done.
Let me give you your devices.
What is it in here?
Oh, suctioning on the perineum. But at
Oh.
that point, you don't know if the baby's going to be a non-breather.
Exactly, exactly.
But you'll
And-
see it. You'll see it. We'll do that.
And so we're not recommending suctioning on the perineum.
Yes. Okay. So, great. Let's dry your baby.
All right, I guess.
Baby doesn't look like it's breathing much. And it's got thick meconium. So
Would
we're
you
gonna
like to take a
suction. Sure. Okay, now we're crying. Okay, that got him crying.
Okay, so I just delivered.
Okay, so the baby is not crying, right? Is that what's is there meconium?
Right there.
There's meconium and there's no crying, so I'm going to stimulate the back to encourage breathing by turning on the side.
Okay.
Yeah,
So
that
I'm
works.
just going to rub really hard
So yeah, she said
Like
squeeze the
that.
squeaker and that at the same time.
and still not crying, so now I'm going to use the
Why isn't my baby
suction.
crying?
And actually, if the baby's not crying, you may even want to clear the airway.
Yeah, that's what I'm looking for.
Oh, the penguin.
Did you lose your penguin?
Think
Oh, we still have
borrow your finger.
Right. So squeeze first and then.
Open the head up,
Yeah.
and then
What
So
happens
if
if
you
you leave
first
the cord on?
there we go.
For an hour.
Like, let it. What would happen
And
eventually?
stuff.
So Nalini tells this story in the Philippines. If you're born at night, your cord stays attached until the sun comes up.
Okay.
And usually
Is
the
that bad?
placenta comes out between the legs of the mother while the mother's sleeping. And
Well, I was at a MANA conference several years ago, and they had this old granny midwife from Mississippi that was sitting in the middle of the circle and telling stories, answering people's questions. And they asked this lady if she had ever had a problem with the placenta not coming out. And she said, dears, I just covered that mama up, covered that baby up, and put him to bed. And in the morning, that placenta was always there. She said, I never had a problem.
I bet she
Never had a problem, never had a hemorrhage.
So because the mother was alive.
Oh, that's some really good stories. I mean,
Yeah.
amazing. Imagine being
So just even with these,
Mississippi
I mean,
and
ideally they're surgical, you know,
Oh,
you're
wow.
putting on,
Better fitting.
you know, well, and that they're sterile gloves.
Wanna write
and,
that book.
and it just because it does stick to your hand, you know,
Okay.
it does come, and you turn it inside out, and you know, the mess is inside, and then you can have a clean pair of gloves.
So it looks like you kind of separate the cups a little bit, so you
Just when I put it on,
make one shorter than the other.
it's just kind of a natural. I mean, I guess you could really pull it up higher,
You can find a clean point.
but you can, yeah,
So you find the cleavage plane.
Yeah.
just like surgery, yeah. And then just, and pulling it, actually I like to take out, you may do the same thing, take the one
Take
side the
them,
other,
yeah,
and then
yeah.
you've got mess contained, and then
Right.
tighten up if you have to. Clearly they're like,
Humongous.
it's embarrassing when like you suture your glove into a woman's perineum because it's like sticking off.
So have you
I
done?
knew that would be no.
No?
When I
Kind of a decorative accessory.
Would you tell us if you had?
Just come around to
I have are, and we probably will skip some of the preliminary parts of this, like introductions, in the interest of time. So I want to welcome everybody here. We are all here to learn a little bit more about prevention, detection, and management of postpartum hemorrhage, which is the leading killer of women around the world. And it might actually be a good idea. Peter in here.
That's what I was going to ask you. Is Peter going to co-facilitate? I'll introduce myself. I'm a pediatrician and I know nothing about this, but sometimes I have to help you.
Thanks. What is happening?
I think Peter's in labor.
Can somebody help us? Somebody help, help. Somebody help. Oh, no, not here. She's living right now. Okay, come on, let's get you to a cleaner place. Let's get you settled. Okay, slow deep breaths. Can somebody help us?
Slow down your breathing.
This is my
Deep breath and
sister.
breathe out.
She just called me. Anybody help us? Somebody help us
I
here?
think Peter's delivering.
What help do you need?
Well, I'm just her sister, and she just started like an hour ago, and I had to convince her to come in. So can anybody help deliver this baby?
I can help you. Are you going to be helping me?
Sure, I can help.
So Peter, it looks like you're delivering your head now. Nice controlled breathing. Okay. Nice and slow. Can I get some blankets or cloths, please? To wipe baby's face. Okay. Okay, excellent. We've got the head here. Let me take a quick break.
We're just going to put this here so we can put the baby up here.
Is the baby breathing?
And we've got one shoulder, we've got two shoulders.
Is it okay? Is it okay? What is it?
Don't know yet. Oh, Peter, you have a baby girl.
My baby!
Congratulations.
Clear fluid.
Dry the baby out. Hear that nice vigorous cry.
All
Maybe if we
right.
can get a dry blanket. Get this one out of here. Okay, do we have a little hat for our baby?
Get your hat.
Did you say it was a girl? Another girl?
Yeah. Oh, are you the mom? I mean, are you the dad?
No. Yes, I should be.
What are you?
Your sister. I'm just a sister.
Congratulations. Okay.
All right. I'll watch this baby.
All right. Peter,
How are you doing? How are you
are
doing?
you feeling okay? Really tired?
I'm tired.
Peter, I need to give you an injection, okay? Okay. We've got some bleeding here.
Peter, do you want me to take the baby for a minute here?
This is
Take the
oxytocin
baby.
to slow the bleeding. Okay. Can we? Okay. Thank you very much.
Is this
Your
amount of
baby's
blood
doing fine.
normal?
Okay.
Was that a lot of blood?
Yeah, we've got a lot of bleeding here. Sorry.
Expert. Then here's a.
Is the baby still
Could you guys
okay?
please help me
Baby's
with the baby?
doing well.
I'm going to take care of Peter here.
Wow, that's a lot of blood.
Okay. So,
Baby's doing well.
I'm trying to
I'm gonna just
do we have
wrap her up.
separation?
Are you feeling
Let me know if
cramps?
there's anything I can do for the mom.
Okay, I'm applying gentle core traction. Bleeding is slowed a little bit.
It seems like
Do we have
a lot of
separation
blood.
here?
Peter?
Oh.
Peter?
Okay.
Oh, that's a lot of blood coming out.
Okay, sorry. We've got, can I get a receiver? Thank you.
Peter? Peter?
Oh, our uterus is not firm.
So the placenta looks intact.
I don't think he has a pulse. Can we
Emergency,
doing
emergency.
well.
Can we call for backup?
Let's see here.
I think he's dead. Oh, I think she's dead.
We have no pulse.
We have no pulse. So, has this ever happened to any of you?
Not me personally.
No. So this role
Yes.
play, this role play,
Better not.
this role play starts out with lots of laughing. People have never seen mamaNatalie, and they are just laughing. Sometimes nobody wants to come forward at first, but then once the baby comes, somebody will come rushing in to deliver. And it's exciting, and it's happy, and we have a baby, and the baby's crying, and then we have the mother, thank you, Peter, progress to a hemorrhage that leads to death. And we get silence pretty amazingly, and then people take their seats. And then, so I'll continue as I would. So, has this happened, or something similar ever happened?
Can I just break in and just make
Yes.
a point? Another thing that happens is that it really allows you to start to see the team dynamics
Right.
in the room. You see who comes forward and who follows who.
Who's actually been playing?
Yeah, and sometimes it's not the person that is
Yeah,
designated that's the leader in the
Right, in the
group either.
And you do see, this is designed to be a facility-based training, so you do see the team jump into play. Now, if it's workshop-based, it's similar. So the field validations were workshop and larger, and from one or two or several facilities with outlying facilities. So in general, some people knew each other, and we could see the team dynamics coming. And so we had this happy icebreaker that's funny, even more funny if it's a man coming in, I'm sure. We haven't done that. We've always had females doing it, at least in the field validation. And then somebody will... So, Susan, you said you have lost a mother, had a near miss from hemorrhage.
Actually, it was not from hemorrhage, but was from an amniotic fluid embolism, but was an arrest.
And so
right after the birth.
we get somebody to talk about either, what that was like, and, and so let's say it was from that, so is there something that you think would have made a difference? And we get them, they talk a little bit more about their context and their situation when, well, we didn't have transportation and she was hemorrhaging, we didn't have blood, we didn't even have an IV giving set, we had nothing, and we just had to watch her hemorrhage. And then we bring the group back and say, well, that's why we're here. This is the #1 killer of women, and this can be prevented. And so what we're going to do today is refresh you for those of you who are comfortable, and let's grab another chair for Susan so she can...
Well, I'm actually... well, if you're going to be doing the stuff here, then I should probably be on the other side.
You want to be on the other side anyways.
Yeah, so no.
I'm staying with the baby.
You can hold the baby. She's a neonatologist.
Sherry, I can share a powerful story from a couple of weeks ago in South
Sure,
Cheyenne.
yes.
We were actually there doing clean and safe birth training and postpartum hemorrhage prevention training. And the last day, a couple of the midwives from the facility came and joined the training. And here we are kind of sort of talking theoretically and hypothetically about these things. And I said, we had this happen last night. There was a girl who was 16, had a concealed pregnancy, delivered in the latrine of her school, and started pulling on the umbilical cord. So she was unconscious by the time she was found. She was brought to the hospital. Her family was furious. Nobody would agree to be a blood donor. This was like the night before, the last day of our training. It made it all so incredibly real. And it was a case of prolonged.
And the reality is, most times when you're in a room like this I've been in, you ask that question, has anybody seen a maternal death? And they have.
Everybody raises their hand, or most everybody, or they can talk about a near miss to hemorrhage. So, backing into the role, so as I said, we're here to refresh or learn how to prevent, detect, and manage postpartum hemorrhage. You may notice, has anybody here had Helping Babies Breathe? So, Everybody this morning. So you may notice that helping babies breathe, and this is helping mothers survive, the bleeding after birth module. So they're designed to be interconnected trainings, and specifically because it's often the same provider who is often alone who is required to take care of both mother and baby. And so both of these trainings are well suited to each other. One of the keys to both of these trainings is continued practice after the training, and we'll talk more about that. So what causes bleeding after birth? Who can bleed after birth? Are there people that we worry more about or less about? Does anybody want to take a stab at who's most at risk? Do we worry about that? Right?
Something with an underlying cause.
Absolutely. Which often in the developing countries we don't know about, but
Multi-gravities.
and so we only worry about those moms, right? Has anybody ever seen a first-time normal healthy mom bleed too much? So yeah, any woman can hemorrhage, and while you might have a little extra prickle on the back of your neck when somebody's coming in with their ninth baby and history of hemorrhage in the last two, any woman can bleed. So we need to be prepared.
I just stop for a procedural thing right now. I see the paper and kind of be taking notes for this.
Do you want to put it up here?
No, I'm just wondering if you're scribing it just in general, like I did the last time.
Yeah,
before.
I was.
That's good. I just want to make sure somebody.
Okay.
Oh yeah, I wanted to.
Go ahead and turn the page since we're out of room, and then we
another
can,
issue
if there's
that we
something
can-
that comes up, then we can, it'll be a continued part of it.
Yeah.
Oh, is that the last page? Yep.
No.
Okay. Next slide. Here you are.
I just want to make sure somebody was taking notes of things that we picked up on.
Thanks for closing that, Joe.
And another question is, ordinarily I would assume that there would be an introductory process.
Right, and
to
when you
find
were out of the room, I
You
said,
did.
we're gonna skip that.
Okay.
In the interest
Okay.
of time, but
Okay.
yeah, absolutely.
Go ahead.
And we do stage it as two people outside the room coming in, and you can get a local person. If you're truly the only provider of the facility, then you work that differently, so we'll talk about that later. So right now we're doing it as a team. So yes, and all bleeding can be life-threatening. Bleeding can be slow, but steady and never stop, or it can be in a large gush, which is more obvious, but both of them can be life-threatening. The purpose of this training is to provide you with the knowledge and skills to be able to prevent, which is key, and also manage bleeding. So there are three main causes of bleeding. Does anyone want to share what those are?
Vaginal uterus,
Okay.
tear,
So that is a cause of antenatal bleeding and can be implicated in postpartum hemorrhage afterwards, but you're on the right track. So placenta that won't come out, or pieces of placenta. Okay, so let's go through those briefly. So the uterus contracts, the uterus bleeds excessively until it contracts or gets hard. Most bleeding after birth is caused by this cause. The uterus just will not contract down. And so you can see on one side what it looks like when it's normal and there is normal amount of bleeding. But if that uterus won't clamp down around those vessels and seal it off, the hemorrhage will ensue. And this could happen to any mother. Any mother can experience this for no specific reason. So we need to be very watchful. The next most common cause of bleeding is remains of either the placenta, the whole placenta, a lobe of the placenta, or even just bits of membrane. And that can not only cause bleeding, but it can cause infection.
So does the membrane really cause bleeding, or is that more risk for infection?
It's more risk for infection, but the uterus does not contract with any foreign matter in it. It does not contract as effectively.
It doesn't have the same.
It doesn't contract as effectively. And you're right, that's a huge infection risk. It's a smaller, I think, hemorrhage risk than like a lobe.
It'll lead to that low-grade trickle over a long
Right.
time, which is
Really?
Right. And then infection.
And is that a risk for DIC also to have retained placenta?
I think anything that could give you massive infection or blood loss, continued blood loss. So it's a good question. I mean, any of those conditions can lead to DIC.
Here's our student. What's DIC? Disseminated intravascular coagulation. So
Which we draw a line at and don't go into.
right. Yeah, we definitely don't go into like the clotting disorder. So when we went, for instance, to Malawi, they had 4 T's. Thrombin is how they worded it. Of course, there are other non-thrombin related, but that was their reminder for coagulation of coagulopathy. Okay. And tears can also cause bleeding. They can be tears that you can see. Those are pretty easy, but tears that you can't see. So cervix can tear, vaginal sulcus tear, those can cause extensive bleeding. What increases the risk for bleeding from tears? Does anybody want to guess some things that might increase risk for tears? For a woman tearing?
Big baby.
A big baby, that's a good obvious one.
Delivery position.
Delivery position.
Yeah.
Well,
Position of baby.
and bringing a position of the baby
Oh, you mean the position.
Like front facing or back facing isn't one of those.
posterior.
Yeah.
It's more, so these are more technical answers than I will often get in the field. But those are all right. So, but also women who've had an episiotomy in the past, but women who have been circumcised. Yeah. So in cases of fibrillation, that is really a significant risk for women.
Sorry, the data actually that not having an episiotomy ever decreases the risk of bleeding?
If you had it, so if you cut an episiotomy, but also prior episiotomy, that I don't know. It's more if you cut
At a certain angle, that's more prone to
tear
tear again than like well, not slightly.
the midline and the
The
medial
medial
line.
Midline episiotomy is more likely to tear on the seam.
And and then if you have cut an episiotomy, for whatever reason, it increases the risk for extension of that. Not only 3rd and 4th degree lacerations, which get into the rectum, but it can cut. Anytime you have a tear that gets extensive, you can tear through a vessel. And there's some nice pumpers down there when you tear right through there that can really bleed.
And women that have been infibulated tear in really grotesque manner.
And really difficult ways because it's scar tissue and so this is something that we would approach more in a country by country. So going to India spurred an interesting discussion because they have more and more immigrants, and the obstetrician gynecologists were talking about what they had seen from immigrants. So it's not part of their culture, but just like in America, we see women who have.
So I guess getting down to my real question is it better from a standpoint of preventing hemorrhage to never make an episiotomy?
Yeah.
Even in a woman.
Unless the woman's been infibulated, and
Right.
then you're better off cutting.
Then you should.
Okay.
Right.
Wow.
And these are, cutting an episiotomy should be done only by an advanced care provider and for very specific reasons. So there are.
Like a medical student.
So who here is in the roles as an advanced care provider?
So we actually didn't
You
go
do.
through who is who. So I'm assuming you're still going to be a pediatrician.
But
You're
sometimes
still a nursing student.
I'm the only one there when a delivery happens.
Right. It happens. And we have a midwife and we have a nurse. So we kept our same roles.
Okay.
And so for cutting an episiotomy, if somebody has been circumcised, if you are sanctioned and have the appropriate training, that is appropriate to do. It's never appropriate to do if you don't have the training. Okay. So before we get into now that we've learned about the causes of bleeding and discussed them a little bit, let's talk about some important things before we actually get to the birth. So communication is vital. It can save lives. So one of the keys is knowing your team members, so who is part of your team. And so this is a similar discussion that we had earlier this morning. Having a communication plan in place is essential, and assigning each team member a role. So in this facility, I think I heard earlier that there's often only one person here. But if there's a second person, it's vital that we alert that second person, whoever they are, when birth is imminent, so they can have their ear out or be present in the room if at all possible. Fear is common in stressful situations, but having good communication can really
keep that at bay and to keep things flowing and prevent delays in care. Speaking loudly and clearly is really important. People can't know what you're thinking, so direct communication. You know, Laura, I need you to go get more medication. So be very specific and very discreet. Actively making decisions for the mother and baby is key. Oftentimes we're really busy, you deliver the baby seems fine, and you run off to care for somebody else. You need to understand what's happening to the mother, what's happening to the baby, and understand that signs of changing conditions for the mother and baby have to be monitored. So how often do you check the mother and baby, in the hours after the baby's born? What's your usual practice here?
Do you want us to be honest?
Sure.
Mm-hmm.
Be honest.
Often I see the nurses have to go to another delivery and they're left alone after maybe 5 or 10 minutes.
So this is in Denver or Uganda?
Uganda.
Okay, just checking. Yeah, right. So signs like blood loss. How much blood? So this hemorrhage that we just experienced was a little bit compacted because women can have a contracted hard uterus and a little bit of bleeding, and you turn your back, the uterus relaxes, fills with blood, and they bleed. Same thing with the baby. Baby looks fine at first, you turn your back and you don't check frequently, you can come back to a baby that's not breathing, and even if a baby that's died or a mother that's died. Actively looking and watching for signs. So it's not just, bleeding is fine, but actually assessing and using what you feel and you see and you hear from the baby and the mother will clue you in on what you need to do and use that information to make decisions for the best interest of the mother and the baby. For the mother, this means looking at bleeding, checking for the tone of the uterus, and we're going to go into this in detail, but every 15 minutes for the first 2 hours, and those are the same times that you'll be checking the baby. Clean and safe deliveries, again, we reviewed this morning. We do this in a little less depth than HVB has done. However, we emphasize that the right clean equipment is vital to safe care and to prevent delays. You need to have that out and ready to go prior to the birth, and that includes drawing up medication that you will be using when we talk about active management of the 3rd stage in order to prevent hemorrhage. It means having the bag and mask tested and ready to go. It means having all the equipment laid out and ready, and this needs to be done in advance of the birth, not waiting until after the baby is crowning and you're looking for the things you need. This is essential to preventing delays in care, because if you can't find the right things you need, that could potentially be very risky for mother and baby. So, for those of you who have had HBB, which in this room it's been everybody, you can see we have an action plan here that looks very similar in layout to the HBB action plan. These 2 action plans work very similarly in that there's the green, which is the normal, and we're going to cover that first, and then when things are not going quite right to when they're going quite wrong. And we're going to review all of that. We're going to have extensive practice with the simulator. And let me show you a little bit. And this is where in a bigger group, I would have people stand up and gather around. In a small group,
But we've actually, we're modeling this for a small group like this.
Yeah,
The
and
whole
we are.
training is based on
a small group,
Small
and in
group at the
fact, you
facility.
guys might end up being even a little closer, or so pull your chairs in or come take a look. And this is where, so let me show you how this works. Has anybody seen this before? And everywhere I've been so far, nobody has seen it except the facilitators. So this is the abdominal skin, okay? And in here is where the baby was. Yeah, so you start off with the baby, of course, inside the uterus. This is a new one, so the cord is kind of tight.
it's good.
Yeah, okay. It snaps tight too. And here's my placenta. And this is the way this training works. You can actually talk somebody through this for the first time. And we've done this at all. You probably did it in Exicon. We did it in DACA, where people volunteered, came up, we strapped it on them, and I whispered in their ear what to do. And so it's not as straightforward as mamaNatalie because it's a little bit different. As Tor says, it's one step more removed than mamaNatalie, but I counter with, yes, it might be one step more removed, but it's also one step more personal because this is a real human. And all right, so you can have a retained load and teach that, and so you work all this from the inside. So this attaches. My cervix ribbon. Okay. So this attaches with Velcro right here. And this attaches to the baby.
And do come up.
Yeah, you can come up and look.
Closer.
And here is the zippers on either side to keep the baby in, and the piece de resistance for hemorrhage is the blood tank.
So Peter
So-
lost 600.
Yeah, this was even more than a liter. So
This is
you push it up to the middle to make it light bleeding, and you push it all the way over to the side for heavy bleeding.
Wow.
and to use this, you got to push a little bit, and then move it
To
over,
release. Okay.
and then it'll snap in, and then again.
So, sorry to be peering
Fine.
into
Peer into my uterus. Peer into my womb. It's a womb with a view.
I feel like I'm invading your personal space.
Well, especially since he's a boy. And so so the baby's out and delivered. One of the really great teaching tools that this is, which is similar to neonatal, but a little bit more complex, is that you can, based on what the learner is doing, you can react as a uterus might react, as the bleeding might react.
So if they massage, you can slow the bleeding type of
Exactly,
thing.
and even more. So I'm going to put this up here. So after birth, we massage the uterus, right? And so you can feel, whether it's soft or hard. So make a soft one and make a hard one. And
It's hard.
This is hard.
Yeah, and then there is some lube.
Yikes.
They call
It's
it
a body
body
uterus. I hate that word.
And I can also make it
high,
high.
and that's where it usually is if the
So
bladder's
this is-
full,
this is
that your
shallow.
umbilicus, right?
Okay.
And I can make it offset to the side if the bladder's full, or.
Yeah. So now, show
And
us
as you,
what you're doing.
if you massage here for a second, I will in a second, Susan. But if you massage and you're massaging appropriately,
With 3 hands,
Then-
no less.
then I can firm it.
Oh, cool.
And move
Under
it down
a
where it's
relative
supposed to be.
reaction.
And with your
Wow.
other hand, you control the bleeding.
And the
Right.
way I'm doing that is there's an air bladder back here.
2 of them.
Two of them. There's one on the inside and one on this side. It's like a figure 8.
So you
So I
to
squeeze
make
the
it-
back, and it
Right.
makes the air go to the front. I let
Cool.
it go, and the air comes back to the back.
Neat.
Cool, huh?
Yeah.
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 This actually, we will get to this toward the end of the training, but you can teach bimanual uterine compression. And for those of us who've delivered babies, you never do that the first time unless it's on a woman who's really bleeding. This gives people a relatively realistic feel for practice. The flesh doesn't feel the same, but midwives and doctors who have done it in India, they were nuts over this. They just thought it was fabulous. So I'm going to rebuild this uterus. I'm going to reinsert
A
your
couple other
baby.
things. I can simulate a retained placenta by holding on to it,
Right.
and not allow it to come out if
Right.
the person's not doing cord contraction in the right manner, or if it's not ready. I can grab some of the placenta and retain it, so that you have retained lobe.
And show them actually down here the straps that so what you do is you hook your hands in to push the skull out when you're doing the delivery.
Okay.
Wait, what are the straps for?
Okay, let's put the baby in for the birth, and we'll show them.
With the
Yeah.
abdominal skin down.
Okay.
And you can put the baby in the
You can do
position you
breech.
want to, yeah, or even different.
Orientation.
Correct.
Can people actually manipulate it?
Yep.
Wow, cool.
So, and this is a cervical strap right here, so this can be tightened.
That's what we'll tight to
But
simulate when you're going to do.
but for the birth, you want it open, and then you don't zip this up, because what you're doing is you're controlling the birth by putting your hands down here in the head. You're actually flexing the head, and you're going
Right.
through the cardinal movements through the birth. So I'm going to start out, and let's start out in LOA here, and then as pelvis, I'm going to move it to OA, and then I'll start to.
Peter, are you using the
start to
ribbons on the
extend.
side?
Yeah, what are you doing with your
Because they actually, so in the manual, they will tell you to have your hand out here,
You know,
outside,
I'm.
and not everybody likes doing
I
that.
don't. I
To
think.
push the head.
I think
Yeah,
it,
that you
I,
push the head
I
out.
think it works so much better
With
by
your
just
hands
putting just
inside.
hands on the head. I can feel the orientation of the head. I
Right,
can feel where
right.
the ears are and know how the
Yeah.
baby's
Oh,
and the
wow.
baby's face and know how it's positioned. So I'm extending now.
His head skin is coming away. So you start in flexion and then you do the
And I'm
extension.
extending for birth. And then the
Wow.
head's out.
That looks
Yeah.
super real.
And then once it's out, I can do an external rotation.
And you can teach and encourage alternative birthing positions. I know in Haidam they did it lying down, or they, with a side lying with a. That was Sheena, I
Leg
think.
up.
Yeah.
And then after the baby, we've done knee chest and all different positions. But after the baby's out,
You need to pull this.
first thing you want to do is pull this strap down, so you get
Okay.
better control
Of that.
the back.
Some people wait till after you get the placenta out to do that. It just depends on.
Yeah, that's probably a better idea.
Which strap did you?
This
Here's
strap
this little-
right here.
Oh, you
So
unhook it.
after the placenta, it is after the placenta.
After the placenta's out.
Yeah, so the placenta is.
And so what we're actually going to go through, so this is whatever time people need to get comfortable with it, but in general, when you're doing the training
That's what everybody
for the
does.
providers, you're basically just showing them how it works so it's not a mystery and they know what they're doing. When you're teaching facilitators, you get in more detail like Peter is doing today about how to.
And we're also laying the groundwork because we recognize that everybody that's sitting around this table, we're going to want to be facilitating this. In low dose, high frequency modality. After we're introducing this, and
But
what they
everyone should
do
be
after we
supported
leave with
after.
this is going to be. So everybody needs to have some basic understanding, and we want them to get some enthusiasm for using the simulator, so that it doesn't become one
Leave the
person's
baby
job
out.
to simulate.
Okay, so we're going to leave the baby out. Does anybody have any more questions? So we're going to leave this attached, and we're going to leave the placenta attached. But we're gonna hang on to the baby because we're
hang on
gonna
to the baby.
we're gonna make it at the moment of birth because we just.
Oh, okay.
It seems like this mamaNatalie has been through several iterations. Is this,
Has been.
is it still, or is this?
It's
we're
pretty
done?
stable.
Yeah,
right
this
now.
is the
Yeah.
most recent, and it's been this way for a year.
The changes are small. Now.
Like they're very small. Like this ribbon was ribbing, and they re-engineered the ribbon. They chose a different ribbon, and they chose a different attachment method. So it's that sort of thing.
Okay.
So what
The
we're going to
idea.
do is we're going to start this off with the baby just delivered once
Okay.
Peter gets back together.
Does this need to, okay.
And that
I see.
covers, that's the skin. So if we could have a blanket so this baby is warm and happy. You lost your squeaker, Peter.
Oh, it's back there.
Isn't it? Oh, okay.
It's not squeaking very well.
So where do you
Oh, because it's stuck in here.
So there's a little holster for it.
A squeaker holder. This is part of
There's
the
no-
local adaptation.
No, it's a layered
Like a
adaptation.
holster.
A squeaker holster, yeah. I don't think they had that to begin with.
Okay, so now we know how the simulator works. We're going to go through the actual steps as if Peter is an actual woman and that we have just delivered the baby onto Peter's chest. So you guys can pull closer, or I don't know, Susan, if you want to come around. I'm going to be getting in
Yeah.
front of you, which
Okay.
I don't want
All right.
to stick my back to you.
I always gravitate over the real baby.
If you feel better, you can hold the baby. Hard to write notes.
I can see her.
Okay. So the first step in active management of the third stage of labor is to give medication. Is to give a uterotonic to prevent or to create contraction of the uterus, so the uterus will contract down and help expel the placenta more quickly. But it's really important that you do one thing first before you give the
Check for another baby.
Check for another baby. That's
Good.
right. That's right. And so you just delivered the baby, you're drying the baby, and you're making sure the baby's fine. You want to give the uterotonic when? Anytime?
No,
You
this
want to give it
time.
right away? Do you want to give it within the first hour, first half hour?
Within 30 minutes, I would say.
Anybody else? within the first minute.
Really?
And you want to get it really quickly. So you're drawing the baby. We've got a new. There absolutely is, and this is a really critical time. And so we've got this baby dried off, and while we're doing that, we're also checking to see is there another baby. As long as the baby is crying, breathing well, and it's not that you set a timer. It's that as soon as you go through the steps, the baby's doing well, the baby's crying. And you have to have it drawn up in advance. It's absolutely vital. So this is drawn up in advance. I didn't break my only vial. Actually, you need 2 of these in developing countries because they're usually 5 milligrams. So what is the dose for oxytocin? What do you guys use in this facility? Do you use oxytocin? Do you use anything? Is there anything else that you use? Yeah. Okay, so there's another drug that you can also use, and that's misoprostol. Misoprostol is a pill. You need to give 3 pills. They're 200 micrograms each, and you need 600 micrograms. The nice thing about misoprostol is that it's considered very effective, and it's not as affected by heat and light. Okay, so this should be kept less than 25 degrees C, ideally kept in the refrigerator, and some taken out for the day or the week, depending on the volume in your facility.
So how long can it be at room temperature?
So as long as 3 months, So yes, it's less than 30 degrees C. So when you get above 30 degrees C, it degrades very rapidly.
Which could happen here.
Yes. And that is a big problem in facilities, keeping in the refrigerator, keeping it in cold storage. Some places it's easier than others, depending on the facility and the setup. So, Mrs. Johnson, I'm going to give you a shot to stop your bleeding. Okay, I'm going to give it to you in your leg. Okay. All right.
Is it IM?
It's an IM shot. So we're seeing how the baby's doing. We're waiting for a contraction, and so at this point, it's
Feeling something.
feeling a contraction now. Okay, and in a training we do. Where's all my stuff? We do put on the glove and the gowns and demonstrate appropriate infection prevention also. Okay, so you're having a contraction? Okay, so it's important not to provide controlled cord traction unless you're trained, unless you are a skilled birth attendant, and only during contractions, and that's vital. Okay, so it's not quite ready yet. Let's look and see.
And how do you tell it's not ready?
So you'll feel it give.
If it's ready, it'll come, right?
Yep. Well, if it's ready,
Lengthening the cord.
yeah, the cord will lengthen, the uterus will change shape a little bit as it pops up. So yeah, I don't have everything that I...
Little gush of blood.
Yeah, gush of blood. Okay. So we're going to go ahead and cut the cord, not with that.
So are you saying, so what are you saying?
He just made a gush of
Made
blood
a little gush of
happen.
blood.
Yeah.
That's a sign of release too.
It's being realistic.
And so
Because that's part of knowing that it's ready.
It's ready, yeah.
And because the operator has their hands full operating, unlike a mother loving the baby off, we will at this point move the baby aside to make teaching a little bit easier.
And that's, it's, if I can just say, there's so much more you can do with more experience with and comfort with the simulator.
Absolutely.
As you get used to this, you can keep the baby, you can do multiple things at the same time. It's really, and the learning curve is pretty fast.
Yeah, I would agree.
And actually what I'm trying to do as an outsider is codify some of those things that you can do, because I think people who aren't used to doing this are going to need a set of things. So to show that the core,
What should you work for?
that you're not ready, that the placenta isn't ready to deliver with cord traction.
Right. Okay.
Yada yada.
So how do you know if a woman is having a contraction? First of all, you could just ask. Sometimes they may be a little sleepy and they may not feel much of a cramp, but you'll see a lengthening of the cord. And so only during the contraction, you provide controlled cord traction in a gentle outward. You notice I'm not like pulling really hard, and I'm not doing this, which we see a lot of in developing countries, so just really gentle. Then when you see it at the opening, and this is where, because of the simulator, it doesn't slip out in a smooth fashion like it does in a real woman. But this is loose, and I just have to just gently. We don't want to teach them to go up inside. and so you just have more help from your operator.
Yeah, and I can actually reach my hand down. If I see that happening, I can reach down and help a little bit. Just try and make. The goal is to make sure that my hand doesn't come out of the.
Right. Yeah, that's a
come
little
out of the
disturbing.
Second baby.
So as you see it coming to the opening of the vagina, you want to cup your hands around it, and you wrap and roll, because there are membranes that are coming along with this. And when you wrap it in this fashion, the membranes will come out, and they'll form a rope, and it'll be much stronger than if you just pull it down. So you're less likely to leave membrane inside. Okay? We do a quick look to make sure that it's complete, and we set it aside. And I need my flip book at a different spot here, so I can go back and forth, but so I'm going to move it.
You said only someone trained in that technique can do that?
So controlled cord traction is to be delivered only by skilled birth attendants. So that's a midwife, a nurse, or a doctor with special training and skills.
Does this training qualify us to do cord traction?
So this is, something that is going to be country specific. So you would think that a midwife anywhere can do controlled cord traction. However, for instance, the auxiliary nurse midwives in India, they're considered skilled birth attendants by the government. They're not really considered skilled birth attendants. They don't meet the definition.
Okay.
So we, in this regard, as regards to controlled cord traction, we have to take the lead of what the country context is, and that's pretty much the end.
Do we have an advanced care note?
And we do, actually.
Show that?
And so that's where, so when we were in the perform controlled cord traction, the advanced care note is what I said early at the beginning, was that controlled cord traction is only for advanced care providers.
Throughout the
skilled
whole
birth
action
attendants.
plan, we point whenever there's a bridge point to what a skilled birth attendant could do if they were trained and authorized versus another person that wasn't. We talk both ways.
I see.
Right. And there's certain things we don't train. For instance, manual removal of the placenta. And so going to the peripheral facility, even if you're trained, if you don't have an IV set, if there's certain things you don't have, you don't want to do that anyways. You want to be able to send.
Well, while we're not training people to do manual removal of the placenta, what we are doing there is helping people to make those clinical decisions and communication,
Right.
and communicate so that they can say, okay, who is the skilled birth attendant
Right.
here among you?
Exactly.
Where might she be? He or she be? How might you access them in the middle of the night if you had to?
And this is right now we're in the green and everything's fine. And so we are staying in the normal. So the placenta came out just fine. And as you can see on this page, it gives a more clear example because there are membranes attached. Laerdal had tried to create membranes and it created too much of an issue.
Some people have done it with plastic bag. You're going to say that?
And we've also taken in Tanzania, we took some, for the next phase, we took some gauze, unfolded it, cut a little hole in it, and made this gauzy thing. So I'll demonstrate that in a minute of what that looks like. But as I said, you do a quick check, you set it aside, because the very next thing that you want to do is check the tone of the uterus. So we've just delivered the placenta. I looked at it quickly. Now is a critical time when she may start bleeding. So actively making decisions for the mother. So right now, her uterus feels a little high, but it's pretty firm and there's no bleeding. So I can be comfortable that that step is okay. And that is combined at the same time. You're feeling, you're looking, and you're checking to see how mother and baby are doing. She's looking good. She's pink.
So as someone who's not used to seeing giving birth, I'm used to sort of looking for a hemorrhage post-surgical, and in those people I sort of know what the baseline is, but in a woman who's just given birth, will they seem out of it no matter what, or will out of it be like something might be going on here?
Yeah, that's a great question. Yeah. Women seem to come alive as soon as that baby is put in their arms. So and now this is an unmedicated, birth, which is basically what we're dealing with.
Right.
So while they still may be uncomfortable, they still may complain of some cramping
But they're going to be like responsive.
They're responsive. Okay. They're connected to the baby.
It should be pretty engaged.
cage.
They are. I mean, it's
Yeah.
it's tracking.
over.
You
So
know,
if
it's
If someone's like lolling, that's a bad sign.
Absolutely.
Or someone which people
Absolutely. And the baby also. I mean, that's this. The mother and baby both. The baby will have this wonderful, quiet, alert state if it's healthy, and they will track on each other. That's So okay, so we've decided the uterus is nice and firm. She's not bleeding at all. I'm checking on the baby, or maybe if sister's holding the baby, I have another look, see how the baby is doing, and then I want to closely examine the placenta. So the way we train people to do it, again, so this, you could envision a piece of filmy gauze over this. Not necessary to do, but sometimes we do it in training. And you want to check both sides of the placenta. So the meaty side is the side toward the mother. If you cup it in your hands, the lobes kind of fit together like the pieces of a puzzle. Okay? And again, this is, of course, a simulation. It's hard to really see. Run your fingers along the outside. See if there's any chunks missing. Look on the back side. Look at the membranes. If you don't see hardly any membranes like this, something's very likely left up inside. So you can see, we started off with the baby's breathing. We checked for a second baby, and we gave medication. In this case, we gave oxytocin. We performed controlled cord traction. The placenta came out. Massaged the uterus. It was complete. We're checking for bleeding. And bleeding is normal. Okay? So you can see, as you're massaging the uterus, you're checking for tone, and you're checking to see the amount of bleeding. You're looking at the placenta, and you're going back to the woman. Is the uterus hard? Is it contracted? And is the bleeding normal?
So how do you tell that bleeding is normal? I have a hard time estimating liquids.
That's a really good question, and it's something we definitely are going to deal with very shortly. So does anybody know what the definition of a postpartum hemorrhage is officially in cc's?
No, I'd guess 500.
Anything more than 500. Now what if a woman is really anemic? Exactly, and that's the right answer. So we don't know what that answer is, and we consider the area of normal up to 500, but we don't use that as anything less than that is fine. If a woman is actively bleeding and she hasn't made it to 500, you need to do something right then. And the other beauty of the training really is we don't have people go just based on the amount of bleeding, because how easy is it to detect when it's on the floor, it's on the bed, it's gone all the way up her back, it's, where is this bleeding? And so we actually are going to do a little blood estimation exercise here shortly. So again, down there, checking again, is the uterus hard and is the bleeding normal? And she is.
Easy to simulate normal.
It's easy to simulate normal. Okay. Keeping in mind, again, that bleeding can be fast or slow. So if there's a constant trickle that had been happening this time that I'm talking, but it just won't stop, that should raise concern that that's normal. We haven't been experiencing that with Mrs. Johnson, so we're okay. Okay, keeping in mind that a full bladder, now she's been in labor, she may not have had a chance to empty her bladder, maybe when she was pushing she didn't void any urine. You'll want to, as part of the checking, and I think as Peter demonstrated, you can have that uterus over there, which is a classic sign that the bladder is filled up and is displacing the uterus. If you're experiencing that, then you want to assist her to get it to go. If you have skills, if the woman can't void and you have skills and authorization training to catheterize, that would be a good time if the woman is bleeding. Absolutely. Okay.
Can a full bladder somehow prevent normal contraction of the uterus?
Yes, that's exactly. So it pushes it over to the side,
Right.
and it blows it up out of proportion to what it should be, and it can keep the uterus from clamping around the vessels. So as a key part of all this, realizing that we've moved the baby away so we could demonstrate more fully, it's imperative that you keep the mom and baby together, at all costs. If mother and baby are healthy, now is the time to get the baby breastfeeding.
You could give me the baby back to reinforce that what we're talking about.
Yeah.
The ring. That would be since after you show them
All right.
mamaNatalie.
And as I
I said, checking and rechecking both the mother and the baby are very critical in this first 2-hour period. Does anybody remember how many times you should come back?
Minutes.
So yes, every 15 minutes, if not more frequently, but at least every 15 minutes. I'm not going to just look
For the first 2 hours.
or peek up, I'm going to actually come put my hands on the mother and feel. And Mrs. Johnson, it feels a little bit soft. Can you feel that? You're not bleeding much, but you can actually massage your own uterus now that we've given you the baby back. And you can put her hand right there and show her this is what soft feels like. And do you see now that I'm rubbing it? It firms it up. Okay?
Yeah.
And so every 15 minutes, and this is when you're going to, now that you've maybe gotten the first 15 minutes of paperwork done. So has the baby latched on yet? Does the baby look ready? And so, so this is an experienced mom, attached, ready to go, so they're doing fine. But don't just see that the baby is there. You want to pull back and just look, see that the baby's moving, breathing, not just laying in her arms, because if the mother's exhausted at this point, falling asleep, she may not be paying attention to whether the baby's truly latched on, breathing well, or crying. All right.
So, a question: what are the classic 3 elements of active management of the 3rd stage of labor?
They are to give the uterotonic.
Tonic.
Now it's okay. Definition
It
with
was
WHO. Definition with WHO has just changed or is in somewhat of flux.
Sorry, I didn't mean this
So-
to be a loaded question.
No,
It's been
unfortunately,
a complex
which
issue
is
for us.
which
a
is why we
complicated factor.
didn't say the active management of the 3rd stage is at the beginning, which is what we were doing. Is that you or me?
Hey, can you pop your head out and see if my son came to move my things? And that's probably him. He's probably at the door. Sorry.
Okay. You
My
moving out?
wife has been shipping things to the house, to the office to take
And that's
home
why you
for-
said it looks like Macy's.
Yes,
Is that-
yeah,
was
it
term
does.
you
It's
used? I'm
all
thinking
There's a lot of
it's all the
Macy's
Black
boxes.
Friday shopping online coming into the office.
It was smart to do it online and not in the stores.
I avoid that like the plague. Anyways, to get back to your question, Susie,
Yeah.
that's a good one. So we did active management of the 3rd stage of labor consists of
Right.
uterotonic,
Yeah.
controlled cord traction,
Yeah.
uterine massage.
And is it really massage?
Not anymore. Yes, it was.
Oh.
So now, and actually, I don't have the latest big version of the flip book. So
Uh-huh.
we.
No, it's not him.
Bosler.
Thank you.
It was Santa.
Hey, got
So
more.
your son was the real deal.
So you may be aware the WHO rather large study that they just completed, looking at the components of active management. So looking at uterotonic, and so they created a simplified package. They did a non-inferiority study where they looked to see if the simplified package, which was uterotonic and checking for bleeding, checking uterine tone, basically, was not inferior to the full package, which included controlled cord traction. And this was the hospital-based study, so it wasn't like they were only going to the community where you wouldn't do controlled cord traction. So they randomized women to those two groups. And so what we are now doing, and now instead of massage uterus, it says check tone. So I don't have any of the large versions of these things, and so we've had to adapt. We have had to have been light on our feet, as far as this is concerned. So check tone, check bleeding. We do, and WHO wants controlled cord traction still to be taught, because when you have, so the normal package, normal birth, placenta delivers everything fine, but when you have a retained placenta, which we're not there yet, you have to, that's one of your first interventions, is controlled cord traction. So the simplified package is only for routine, normal. They identified that uterotonic was the most important feature. And then, of course, making sure that the woman didn't bleed to death because she wasn't checked on. A lot of midwives were uncomfortable, well, maybe me and some others, of removing the 3rd stage, the 3rd component of massage every 15 minutes, because if we didn't have them actually do something, they're not going to do anything.
Right.
We barely can get them to do that as it is because they're often so busy. And women die in puddles of blood all the time because people are too busy to go in and check. And so check tone, so check the uterine tone every 15 minutes requires a hand on the belly to see. And so that's...
Okay.
Yes.
John, come on in. Sorry.
Your dad just gave birth.
I just gave birth, Sean.
Really?
Yeah.
He can't get up right now.
He can't get up
I'm
right now.
hemorrhaging. My son, Sean.
Hey, Sean.
Upstairs.
You love this, don't you?
Are you used to it?
Dad?
What?
Are you used to
You want to deliver my baby?
No, it's just cool. It's just
Oh.
interesting.
You can stay and
We have
you
an
can stay
upstairs
and work
too.
if you want.
Come join
Yeah.
us.
Yeah, I'd like to. I'm a little nervous because I'm in a not parkable spot.
Oh, okay.
You're illegally
Go
parked.
up to the.
But
You're illegally parked.
it's in this reserve spot right here.
That's probably, yeah.
For the
not
CEO.
Yeah.
Your
Yeah.
Wesley spot.
Not a problem.
I felt like it was okay in a strange
It
sense.
won't be. I don't know yet. Okay, you're for the record. I did not
Okay.
know.
I'll talk to
Hear
you.
any of that?
Oh, I didn't hear that. The third. You know where my office is, right?
No, I mean, how much stuff is it?
It's 2 boxes underneath the table and all the things on top
Does
of the
he need
table.
that trolley?
And you can take that trolley.
Just take the
Yeah,
box
because
out?
I didn't
Yeah, take that trolley with you.
I didn't bring a dolly.
My office. Get off the elevator and take a right.
After you walk a little ways, don't have to walk.
Third
If he
floor.
takes a right, he'll go into contracts.
Third floor, take over, right?
Yeah, just through the little, just through the little library. There's a little library room. You'll see the books,
Okay.
and then keep going to the front of the building, and you'll see my name on the
Ask
office.
anybody there.
Yeah, ask
There's
anybody.
Peter's office. I'm here to
Peter's
provide.
office.
Yeah, you'll see it's the one with all the boxes in it. And all the boxes I want you to take are underneath that desk and on top of it.
Okay.
Okay?
Alright. I'll call you. Okay.
Don't forget the ones under it.
Okay.
Okay.
So
Thank
how
you.
many? Like 10?
Huh?
About how many? Oh, whatever.
About 6.
Okay.
Okay, and then take them up to our bedroom, okay?
Okay.
The 2 heavy ones you don't have to take up. You leave those in the kitchen.
Okay.
Okay. Love you, son.
So actually, we give out the facilitation guide at the end of training because we don't want people to be thumbing through it while we are doing the training. But I'm going to give this to you guys now.
This has a different action
Because
plan.
this has a different action plan, and actually this is probably different than the last one that you saw, because Ann and I just had to do some swapping of graphics to make something here more clear that we thought was not clear. So,
For you as well. Instead of this.
Yeah.
right, and you will notice down here, if you compare it to the last version you have, and I don't have to go in, it was technical and graphics change that we needed to make, and so it is different than the big one that we have on here. However, it doesn't change the steps. And while in the flip book it says check tone, so we make sure that all of this matches in here. But this is the big version that I had for teaching. I have a little one, but you'd be like right up here, foreheads staring at it to go see it. So, okay. Also, what's not on here is this next page doesn't look like this. This next page, this is where we break for practice, and we have a page denoting breaking for practice, and I'm actually going to pull that out. So what we do is say, okay, mother and baby are fine. We've talked about, what that means. So now we're all going to come up, and everybody's going to practice, and we're going to practice these steps in sequence over and over till people are comfortable. We're going to talk you through it, and this is where you don't need me. This is where it's one facilitator in really great interaction with individual learners, with the learners standing around, providing feedback, providing support, potentially working in teams. However, if they identify we're always here by ourselves, then they do it by themselves. Okay?
So Peter, can you facilitate from your perspective?
It's an it's a really interesting question, Susan, and I will tell you, I did a training with Ellen Nielsen in Haydn. I did a series of trainings, and I was watching the people that we were preparing as trainers. We had a one-day TOT, preparing facilitators, and then we immediately sent them to start doing the training, and we were there watching them.
Mm-hmm.
And I was watching these. Is that you?
No.
It's probably me and my. Do you go into my pocket there and see? I'm kind of.
coming out of body extension.
Yes. Thank you.
What pocket?
Should be in one of my jacket pockets. So I was watching people that were really the people that were the highest performers. And I really felt
That
like,
was Sean just now.
oh,
I can take up where you left off.
I was going to say, I really felt like people that had some experience doing this could start to do both roles at the same time. Now I found within the 2 days that I was with them, on the second day, the person wasn't quite there yet.
Yeah.
You could have done that,
But I'm confident that I could
yeah.
right now do.
And you're
both
talking
roles.
about doing all of it with the flip book, and yeah,
No,
or
no.
just right
No,
now.
I mean just so now we're going into the exercise
Right.
for routine
Yes.
care. Basically, can you control the actions of mamaNatalie and
Provide guidance.
provide feedback?
Oh yeah,
That's easy.
Yeah,
and
that's
actually
easy.
watching in India, in Malawi, and in
Hey.
Zanzibar, they were all.
Find it?
It was amazing to watch them in action.
Yeah, thanks
Because there's
too.
a lot
Everything
of
that's on that
peer
table, okay?
feedback, too.
Not even. You'd be surprised. I mean, they're encouraged
Yeah, and
to do
then there's
so.
the two then there's the two
You'll
boxes
see
of
the
wine
dynamic.
underneath
So
the
we have a
underneath.
6-to-1 ratio that we tested to see if people could get enough training. It's,
Okay.
of course, better if there's
Yeah, they're
fewer,
heavy,
but I
and
would
then
say
everything
not
else is light
necessarily
and just they're on
one-to-one.
top, okay?
It's nice to,
Right.
because you're also trying to teach teamwork, and that's part of what you model.
Yeah.
And so watching,
Okay,
we even
sounds
did
good,
the
Sean.
OSCEs
Thank you.
with one
Bye-bye.
assessor operating mamaNatalie, interacting with the person being assessed.
Okay, so then.
And it was amazing to watch.
Okay.
And and not all of these were the master trainers, like Peter and Rosemary and Sheena. I mean, they all had some training experience. The ones, and they were all Jupaigo trained trainers, but they weren't all Jupaigo people.
And the people in Haida when we did it had no
the ones that
training
you
experience.
did, right?
And we did a one-day TOT with no training experience, and they were, I would say that 10% were, I think we did 8 trainers, we prepared 8 trainers. I'd say one was a bust that was there for political reasons.
Yeah.
A couple were competent at the end of the 2 days, and 5 of them were doing better than I could because they understood the local context.
Yeah. Yeah. Cool.
It was.
And I would say we've seen about the same with our trainers. But I think one thing that I'd like to put on the parking lot is
Please.
the difference between train the trainer hand-picked group and then trying to make every participant an ultimate facilitator. Because we've also seen that there are some people who can go away doing this stuff, but clearly they.
Well, we can park like that. I mean, I think we see some of those people as being like the peer facilitator, or coordinator in the role. But then everybody, trying to encourage everybody's role in continuing that facilitation.
Yeah.
It's like not unlike the paired learning that you were just doing with the neonatal. My dream, my vision is to see if you got a midwife and a non-skilled person that's there in the middle of the night and it's quiet, they'll strap on mamaNatalie and they'll do a couple births and a couple hemorrhages.
Okay.
And so the next page, which I'm not showing you because the next page goes into problems, is this page. And basically, what it is the learning activities that are coming, and it shows the tracing in the green. So that's the page that should be on there now, but it's not.
Okay.
I mean, I would flip it over, but I'll show you retained placenta, and we're not there yet. And so basically, this is the facilitator's guide to, okay, everybody, it's time for tea break. And usually by the time we get going, it is time for tea break, just as the amount of time it takes for introductions and then going through this first part. And we had some things I probably...
Oh, sorry.
Some things we did probably a little faster, like we didn't do the introductions, and some things we've broken and taken more time because we're kind of digging down into some of the issues of training. So at this point, I'm going to get back into my training role. So it's time to break for tea. So what I'd like you to do, we have 4 stations set up over here. Pretend that we do. And with these stations, and it says on the back what they are and what is supposed to be in them. So we have 600 cc's in a white towel or culturally appropriate cloth in a basin. We have a gauze bandage with 100 cc's in a smaller basin. and we have liquid in a bowl, 300 cc's, and then we use red fruit jam and a little bit of mamaNatalie blood to make a blood clot. And so go have your break on your way back, file through and just write down A, B, C, and D. You'll see them labeled. Write down how much you think it is. Okay, and then everybody comes back from tea break, and we'll be back in 10 minutes, and we go around and say, okay, so what does everybody think was in A? What does everybody think was in B? Because right now we've done everything's normal. In fact, we actually load the blood back into the, and it's very easy to do. You just unhook it. The operator, yeah, sure. Yeah. The operator lifts it up.
Would you hold my baby? I'd be happy to hold your baby.
I only trust you. Thank you, Sean.
Nice to meet you, Sean.
Yeah, you too. Bye.
And so for all of these sorts of things, you can get everybody in the audience to help you.
And this blood, we are told, is water soluble and will not
Doesn't
stain your
stain.
clothing.
Will that stain your beautiful striped shirt?
Not if Sherry doesn't.
Well, so we lift it up from the bottom for me, just a little bit.
Hang on.
Is it leaking?
Just a little bit on my pants, I think.
Sorry, Peter.
That's okay.
Peter.
I'll
Whatever.
dry clean.
Just a little bit of it.
So it's that. So wait a minute,
Foreshadow.
Laura, you were with Shanna, and you guys used
Hibiscus tea.
hibiscus tea.
Hibiscus tea.
Yeah, which does
Which
stain.
would stain, yeah.
Yes, we use that as a dye. Don't we? Okay, so all right. So this opens the discussion for what we discussed earlier. So if it comes up earlier, we won't rehash it like it did in our group. Susan asked, "How do you know how much blood is too much?" If it hasn't come up before, then this is where we make sure it comes up. How do you know how much is too much? When it's, so we go through that whole discussion, and then we segue that into, yes, how much blood matters, but it doesn't matter in a rigid form. If the woman has lost less than 500 and she's sweating and she's not feeling good, and even if her uterus is hard, you need to be concerned. Okay?
And your estimate is unreliable.
And that's the other thing, is estimate is unreliable, and what you will find, people will underestimate. And you'll say, it's interesting for all of these, and for most of the trainings this was the case. People wildly underestimate. We also had chocolate candies for people who guessed right, which was a big hit. So, vital signs are important, and because you guys had brought up, I think maybe Nalini had a question about, what about bringing vital signs? Kind of for the same reason. We don't say, well, if it's above 100, it's a little bit less directive as it is with neonatal resuscitation. A heart rate of above this, you do this. A heart rate of below this, it's not like that. It doesn't mean we don't want them to pay attention. So what we did add was the definition of shock and what the blood pressure and the pulse parameters. So that's in the latest version that you had that I sent you. I think I put in what I sent last night that version has some typos in it that Anne has addressed half of them, and we're working on the other half. So you will find sentences that are strangely cut off. Yeah. Because we put it in the smaller format, because Tori had asked, make it this short booklet. Right. And so I thought it was just a simple cut and paste thing, but with the InDesign graphic program, it's not that simple. They have to. Anyway, so there have been some weird hiccups in some things. Okay. So and some outright errors that we're fixing. So.
But that's the version with the definition of shock.
Right, and we don't actually have it like in a glossary. We actually talk about, when you get to bleeding too much. And so we're not there yet because we haven't hemorrhaged.
So what, I'm asking this in all naivete, is what I'm looking for a delta in vital signs? That this is the woman's baseline and this is a change, that her respiration goes up, that her heart rate goes up, that her capillary refill changes, or are these people taking blood pressure?
Some of this is recognizing that in these facilities that we go to, there's not even a functioning blood pressure cuff. And we don't, and you experienced that on your last trip, probably everywhere you went. So it doesn't mean that you can't check a pulse, but they are so busy doing these basic tasks, and looking at the woman's response and the baby's response is infinitely more important than any number that they're going to record or write down. It doesn't mean that we're saying, we don't take vital signs and we don't record. And in fact, as part of EMONC training, with the every 15-minute checks comes vital signs. Right.
But is that truly the criterion? I'm just trying to drill down to what do I as a provider cue off of?
And so they, as providers who are teaching, don't cue off of any of that. And you will look in the guidelines. In fact, I had Barb Deller help me with this, who was involved in writing the impact manual for managing complications in pregnancy. And she laughed when I asked her, because this is an old problem that comes up and up. And you will find WHO doesn't have anything in their postpartum hemorrhage, nor any.
Does not surprise me.
However, because for some of it, it's because of these reasons. If you are telling people, well, this blood pressure and this, this systolic over this diastolic, unlike preeclampsia, which is a little different because if it's this, you're going to treat with that. If it's under that, so the definition is firm. For postpartum hemorrhage, people collapse at, I run at like 90 over 60. So that's, but you're right, it's the delta, the change you're talking about. But it gets more complicated than what we're going to be able to train out in the, for this purpose in the very remote facilities.
I mean, down the road, we could be talking, though, more about, about the importance of baseline assessment of vital signs as part of, even as part of antenatal care, and recording that so that you
when you
can
have
make
time
this cut.
to,
Yeah.
yeah.
But I'm thinking about even my own practice and managing hemorrhage and what I was taught and what I do, and vital signs isn't a big part of it. Not part of your management.
And I think your obstetricians would say the same thing.
Is it more a gestalt? Is it more an appearance or a behavior?
A diaphoretic woman, a pale woman, and a woman who's it's very overt.
Yeah.
It's kind of like assessing the baby. The limbs versus,
That's not right.
Right.
There's...
And delivering babies, we know, and that was a great question you asked, because I don't think you haven't spent much time,
I've seen 3 women who've,
Yeah, and in general, and I think it's it must be something we're wired to do, because being in labor 36 hours, and you are tracking, you're focusing, yes, you fall into a deep sleep after that because you're exhausted, but
the only time it's an issue is when you get a woman that really does get shocky, and you start to see those signs of shock.
What do you mean?
That's when I start thinking, and it's only happened a few times in my career, but those are the times where I've called for vital signs.
Right. And so we have, so in our context, they've often got the automatic cuff that goes off every 15 minutes, and it'll beep at us if it's below whatever the set point is. And of course we record it. But it's not like the decisions you make. Also for adult resuscitation, there are specific if this, then this, and the drugs, and like neonatal resuscitation. If the heart rate is below 100, see, I haven't had neonatal resuscitation.
But it's really beyond the scope of this.
It's beyond the scope of the course. We want people to act on what they see and feel.
And the reason I'm kind of pushing on this is because a large theme of what we were trying to do was making the invisible visible. And I think there is a certain pattern recognition and a certain intuitive sense that cues you into this. And if you can make that, you can articulate that and make it visible to a novice provider, then you're miles down the road in their maturation. So I think we've all been asking kind of the same questions, like how do I recognize this as a surgical nurse? And I'm asking, how do I recognize this as a pediatrician? What are your secrets?
But the other thing is that doesn't happen. That doesn't happen in the absence of the other things that we're talking about. You're going to see pretty profound bleeding, or you're going to see pretty prolonged bleeding. You're going to see a uterus that's soft, a laceration. You're going to see some of these precursors before you get to that, and you're kind of cued in, and if you're seeing all those things, you're not surprised when you start to see a woman get pale, unresponsive, and diaphoretic.
And the specific motivation for my question was sort of knowing in a realistic context I might not have vital signs, and even if I recognized the change in the vital signs more than I recognized, this person isn't responding to me. Like I want to ask about what am I going to be able to tell from just looking at this person?
Right.
It's going to be their color, their awareness, and
And the other thing is, even if you take a pulse and the pulse is weak and thready, fast, you're going to do the same thing anyhow.
Well, and another point, if you're talking, sorry, Peter, if you're talking about baseline is often when the woman is in labor and her pulse is likely going to be elevated from stress and, whatever. And so after delivery, a normal delivery, her pulse may settle down. If she starts to bleed, she may just be back up at baseline instead of being at 75 or whatever. She's up to 100, which is and so we don't want people narrowing in on those clues. And not that even mentioning them would make it exclusive, and we will talk about it. So far, we're normal.
Right.
And
a normal
also,
birth is going to involve abnormal vital signs, right?
Yes.
Classic
Exertional.
That's a great, that's a good word, because that's exactly, it's exertional. Respirations are going to be different, definitely pulse, blood pressure. Some of those things are pain related. And so when we do get into the abnormal, we will touch on it more. Also understanding that we are teaching providers. This is not pre-service education at this point, it's in service. We're teaching providers, so whether they're experienced, high level, very good, or they have minimal experience with poor training, they have been attending births. And you don't have to attend very many to know what normal looks like. Just, I'm talking very basic, how women respond when they give birth, how they interact with you after they give birth. And so we're building on those things that have been taught in pre-service education. Okay, so I think, go ahead, Laura.
This is an unrelated question, and I probably should know the answer to it. It's about the relationship between these two trainings, because I'm thinking the audience is probably identical for both. And I'm imagining in my own mind the algorithm we had from Helping Babies being superimposed on this, because this is the same time frame that we're talking about here.
The golden minute.
Yeah, and sort of immediately thereafter. Are they meant to be taught together? What's the vision?
So yeah, we designed this with a look and feel similar to HBB. Will they be taught on the same day or the same set of days? That's variable. Right now, that's not what we're
I would
planning.
recommend that.
Right. So you teach
They
one.
mutually reinforce each other.
Yeah. You teach one. You let it soak in. You give them more intensive practice periods. Then you come in and you teach the other. You do it on site. So one day is less invasive. You're not pulling people out of facilities. You're coming to them, giving them a short training. And honestly, without all this extra discussion that we're having right now, in a facility, we could train half the providers in the morning and half the providers in the afternoon. As far as the core practice, which is really what's important, is the core practice and clinical decision-making skills. People can circulate in and out if they have to. And now we're talking about a small facility because that's what this is getting to the more rural areas. And we may end up in larger facilities. So if you have 20 providers that interact with labor and delivery with the labor board, then you will have either an extra facilitator or extra facilitators, or you'll do it on separate days. So where we're heading in Uganda is relatively sparse. Level 2s, level 3 facilities. So there's 4 and 5 facilities. We're not going to those. Those are district level and referral. We're getting out to where women are more likely to deliver and to come in with complications, prolonged labors, come in hemorrhaging, coming in, precipitously delivering a baby that's not breathing, where the resources are relatively limited.
Run with your thought. What else were you thinking about? Because that's exactly what.
Yeah, if we put 2 of these on top of each other, it's going to be a mess. They're going to need to be side by. I mean, already this is more complicated than HPV, but we've got 3 causes of bleeding that we need to, with different, and that's why the training is different. You don't have to go into primary and secondary apnea because it doesn't matter. Bleeding, it does matter because if it's apnea, you're going to do one thing. If it's retained center, you're going to do something else. And so similar things, but the way you're going to resolve those issues are different. And so we have to kind of break it apart.
I have actually had dreams about putting them side by side and trying to trace a path between the 2 of them. Though they're on a little different time scale, as you say.
Yeah, our time is not necessarily a minute.
Yeah, our time goes on, significantly longer.
I think there's an expansion of time for helping babies breathe. There's a little time warp.
But you're helping babies breathe. The green goes longer than the yellow does. It's you got to be a little abstract about it.
Yeah, but you got to make it digestible.
I think we might be able to put the green zones together, and might be able to put a green and a green for mom and a yellow for baby together, and
Right. Well, and this speaks to what we're doing without the rest of you here tomorrow or more the next day, because in Uganda we're testing how do these interplay with each other, and
How to get the synergy.
how to get the synergy.
That's to be seen.
And with the way we have conceptually designed it, train in one, practice for 2 months, train in the other, practice for 2 months. At the end of that time, 1 month, we're talking at the facility. They practice joint scenarios. So normal baby, and so we did actually do a little bit of that. I mean, you have to deliver a baby and do all those things and take care of the mother anyways. Also keeping in mind that providers are practicing this with every birth. This part, they're practicing with every birth. It's it's not just like drawing a baby, but that's a little bit less complicated than the steps that they practice at every birth. Once you get into bag and mass, that's really pretty foreign, and actually probably very foreign to all the providers we go to in Uganda. They might know what
It's a low frequency, high criticality skill.
Yeah,
where this is a
absolutely.
high frequency, high criticality skill. And it makes them a little different.
And it makes this easier to retain once you can get it ingrained. I mean, this was not the hardest thing I learned.
Because you're repeating it so often.
Because every birth.
Yeah.
And that's
Right.
every birth. Okay.
As opposed to things that come into the yellow and the red.
Right, as opposed to, our things that come into the yellow and the red. So we've spent a lot of time chatting, but I think it might be good to at least demonstrate with one of you or all of you if you want to what it's like with one provider. And so I, at the trainings, am typically kind of fly on the wall and blood refiller as necessary and snapping pictures, and because it's the local trainers that are doing the training.
And the other thing I'm doing here, I've been doing what I've done this, I haven't done it as much as you have, Sherry, but I've been looking through this whole thing. I'm doing an assessment of the team that I have in front of me. And if I have somebody that seems like they really are pretty proficient and they're a leader in this group, I may very well, after the first go-around, put mamaNatalie on them and have them start right from there doing it.
And we actually
sit back and watch.
It's almost organic because in Zanzibar, in India, I have to say my trainers are very proprietary about their mamaNatalies. In India and Malawi, not with this first batch of practice. So we talk for a little bit less than I talked, and then we spend all this time we've been talking, practicing, and they get more comfortable with the simulator, they get more comfortable with each other. We come back and we talk really briefly because there's two relatively, there's two complications. We don't have to go through all this stuff that we already did. We're talking about retained placenta, which is really basically straightforward with what you do, and then atony. We break back into these groups, or if it's a small group, you're all together. And that's when people have loosened up, you go through the complications, and that's when I would see, why don't you put it on? Because honestly, the facilitators can get tired from doing this all day long. Now we're at the end of the day, and then people are excited, and they want to do it, and they put it on, and then you're watching them teach each other. And these are the people that we would be identifying as, we're calling them peer training coordinators. I'm not sure that that's the name we'll keep, but you, as a facilitator, you are to identify who that person is. Understanding that there's going to be some political sensitivities, I think, as to who is gifted the mamaNatalie to be in charge of her care and keeping, and also the low-dose, high-frequency practice, and who will also ideally be the same person when we come back in the second training.
The accountable one.
So can I have the baby back, ma'am? Because the way
No, I'm sorry.
Wake up, little baby. So basically, we for this particular, when we start practice, I don't actually start with delivery each time.
Yeah.
We do sometimes with like the first one because they just want to deliver this baby, and you can see it takes a little bit of time. But I'm looking for the cord because I'm going to put her on your belly.
You're going to put her on my belly?
Yeah, I'm going to put the.
You're looking for the umbilical cord.
Yeah, sorry.
Placenta.
There we go. Okay.
So can you have somebody come in and just bleed, in other words? Like they already delivered and they come in and just bleed?
Which would be why somebody might come into a very rural facility, especially in a context.
We're going to put the baby in here this
No,
time?
no. Since we're a little pressed for time, let's not.
Oh, we're not going to do it. Okay.
No, let's have the baby just on your belly.
Okay, and in that case,
Yeah,
sorry, put the cord out. Let's see. Here's the vagina.
So we'll start this out with
do that, but
Yeah.
my instruments are gone. I came back, mamaNatalie was broken, so like,
See, if
got
it
a
happens
baby
here, you
coming
know
up.
it's going to happen in the field.
Exactly. Okay, so what we do, so everybody gathers around and stands up. So if you guys don't feel like standing up, you don't have to, but in general, everybody's standing around.
I had to put on gloves. I don't know why.
No, absolutely. And we encourage people. And so we have enough gloves. People can certainly wear gloves. So what we tell people is, what I have to tell people and how we run the training is to say, okay, who's going to be my first subject? And I can let, you've just delivered this baby onto this belly. And actually, we usually have that dry cloth there. So proceed just as you would normally. And Peter's going to be the facilitator, and I'm going to stop talking. Can do.
Okay. Do we have to go through the whole drying and blanket and all that?
Yep,
Or do
Yep.
you
Yep, we want to reinforce.
Yes, we
I'm
do.
just going to dry up your baby.
What we don't want people to be doing is siloing
I love
and
chocolate.
think, okay, I've done HBB and now I'm not going to do this anymore.
Yeah, that's
I've done-
true. Because it is actually the same bird.
Yep.
Yeah.
Okay, just hold it right next to your skin and you can work like this. How are you feeling?
I feel good. So much better than I did before.
Is the baby crying?
Like in my past life.
Baby breathing, baby. And
Isn't he cute?
yes, he's adorable.
They told me I should have him circumcised.
A soft uterus, yes.
That Laura
That is
Fitzgerald was
good
out
practice.
telling me.
So I remember sorry, to sort of hold on. We have a soft uterus, and I know that
Oh,
needs to be
wait a
hard.
second.
And
What-
within a
what-
minute,
Don't bleed,
Okay,
don't bleed.
no. I'm making the uterus hard. This is normal.
You can bleed a little here. Just bleed in the bucket, please.
okay.
Well, the uterus would be hard. The placenta's not out yet.
Oh.
So you'd expect the uterus to
Be
be
relatively
relatively
firm
firm.
and big.
Okay.
Yeah.
From having the two trainings today this morning, what is the priority? Is it getting the cord cut, or should I be giving the?
How,
So the
long, how
oxytocin-
long has it been since you?
It's been about 30 seconds since this
Okay.
baby's popped out.
Okay, so we want at least a minute before.
Yeah, you might want to untie that cord.
It's still pulsing.
And how quickly do you want to give the oxytocin?
Within a minute of when the placenta is delivered.
No, minute of the
Within
birth.
delivery.
Minute of the birth.
Okay.
Don't feel bad. Usually people who are doing this have delivered babies before. So,
No, it's
you know.
okay.
So it's all right.
Okay, so it's pulled up ahead of time, and I'm going to give you a shot in your leg, okay?
I might have you think I might have another baby?
Is there any reason not to do
I
that?
don't know
Oh,
if
yeah.
I have twins or not.
I was just in an actual simulation for our new MFN unit, an actual simulation. That sounds kind of strange, doesn't it? But it was supposed to be a singleton birth of the fully computerized mannequin, and yes, that baby was born in the ED, and my team was already working on it, but I stayed by to talk to the mom, and
Here comes the placenta, or
No.
here comes the second
here
baby.
comes the second baby,
I love
which
it.
was not supposed to be in the scenario at
Oh
all,
my
but it
gosh.
was
Was programmed
a
that
baby
way.
that was programmed into the mom.
Oh,
So I
wow.
said, "There's a second baby," which created chaos among the
Oh my gosh.
people who were
The
running
plan
simulation.
Here's a better story. That's what I
You
used to-
feel. And
My
so
first day at the hospital where I work now, where I do work clinically now, like 8 years ago, I came in and they had a routine established. We took over, they closed a residency program down, so a group of midwives came in and we argued successfully against doing a routine ultrasound on everybody that came into labor. Because, we said, I can tell if there's, I can tell a position the baby's in, and I can tell if there's more than one baby.
Yeah.
My first day there, I had an undiagnosed set of twins come in, and the first baby was born, and I looked, and the uterus was still
We're still
Pretty
big, and then I noticed there was still some movement. And
Bummer.
luckily it was a simple vertex vortex twins and they were born fine.
Oh my gosh.
Made you sweat a little bit.
You got some stories. Okay, so I was poking around in the uterus, and what I was really doing was looking for a second baby.
Okay. and there is no second baby.
Great. Otherwise, I would have found it.
Yeah, it's pretty obvious after a baby comes out if there's a second baby.
Okay.
Uterus is pretty soft and baggy at that point.
Okay. Okay. So then I'm going to give you an IM shot of oxytocin.
And then we will often stop, and just make sure people, part of what we're doing, which is great with mamaNatalie, is there's a real person there.
Yeah.
So when you see people telling me that, we will say, talk to your patient, because you'll find people don't. They just do without talking.
You're
Which
doing
you
a nice
do.
job.
Yep.
Yeah. I feel very comfortable and secure with you.
Good. I'm glad to hear it. So now we can do the.
What's your name?
My name is Leah.
I'm going to name her Leah.
Oh, that's so sweet.
Wasn't it a boy?
Before?
Leo.
You can name my boy Leah.
How are you feeling, man?
I'm fine. I'm starting to feel a little crampy though.
Okay, well that's normal. You should have some contractions.
And so that's fine
soon.
if she's saying that she feels crampy, but you don't see a lot of blood, or you don't see, you can
Right,
keep going
because
with what
the
you're doing.
oxytocin should be. So we're gonna cut with a knife, actually.
We've had a couple of the cords actually cut. So we,
Yeah,
Take scissors
watch
off the
people
table.
so they don't.
Yeah.
when we're
Just
doing,
pop it.
actually
Just pop
cut
it.
it?
there's a bunch of people
Right.
practicing.
Oh, okay.
Maybe those
We'll-
plastic knives are
Yeah.
a good idea.
I think they're a great idea.
And I'm not a trained provider, but let's say I am.
Okay, and
Right.
so you'll have a clamp. You have a clamp on there, and this is what we'll be teaching. But you clamp
My
close to the
training
perineum.
was there as well.
That's okay.
Sherry, can you clamp this cord
Oh, we get some
repeatedly
bleeding.
Yes, you can.
without?
Well, you know what? Your cord is a little. No, this is our baby, isn't it? Or is this your baby?
I don't know.
Yeah, no, that feels the same as
this
ours.
doesn't have a helmet on it.
I think these are both.
Yeah.
Well, we had one
babies.
inside our. I'm not sure which one it was. No,
No.
this is ours. Yeah, because yours had the tubes on it. And
But we don't have
Yeah,
we don't have a helmet on the baby. It still worked. Hmm?
So if I were a skilled provider, I'm applying gentle
Downward pressure. That's
pressure.
yep. And I'll let Peter.
And do you have to have a hand?
And there was a little bit of
You have to
to
guard,
feel the contraction.
and you also guard the uterus,
And what's that maneuver?
sorry.
guarding the fundus of the uterus as you provide controlled
Is there
cord
a uterus
traction.
here? I just feel your hand.
You guys stop holding hands under the So what's guarding the uterus, Sherry?
I should be holding like this. Okay.
Until you see it at the opening, and
And I do.
then it's free.
Okay, so then I can. So then I know that it's detached from the uterus for sure.
Time to, yep, you roll it.
Yeah, if you see it. It's,
Woo! I popped right out there.
Yeah, that doesn't happen usually in real life.
Okay.
It's a limitation of the simulator.
And I check that it's intact for my quick check. And then I went into
So
uterine
as soon as it
massage.
comes out,
Yeah.
sorry, I said I was going to let Peter talk. So.
okay, no, it's okay.
Feels good.
Well,
It's
part
nice
of
and
it,
hard.
Peter's, you're
You know how it's
demonstrating that
like?
you can do it. You can
Yeah.
operate it and teach.
Okay, that's how it's supposed to be. That's good.
Okay, good. You did a very nice job.
Okay, good. We want to work on breastfeeding now.
And then as part of facilitation, we'll say, okay, so how often are you going to come back and check?
Every 15 minutes for the first 2 hours.
And what are you going to check?
This
Make
baby's
sure
hurting my
that-
nipples.
Probably normal.
I don't remember that
check to
from
make
when we were in
sure
school.
that the baby has good color and is breathing or active and flexed
My
and
baby peed on me.
would be concerned would be seeing more blood and mom that was showing signs of shock, as we talked about. I don't know if that's part of the training normally, but sweaty or out of it or pale, threatened pulse.
Does somebody else want to give it a try?
Attach.
I don't think I want to be a midwife. It's scary.
You did a great job.
Thank you.
You did a great job. And now I'm resetting this. I'm putting I had lowered, I had taken the strap off. I'm putting that back on.
You've got lots of blood.
Can a mamaNatalie do twins?
Pardon?
Can a mamaNatalie do twins?
You know,
I haven't. They say that you can, but
It's
you
not
have
a
to
baby.
you have to
if
deflate
you
the baby.
underinflated the babies, I think. And it makes the twins are smaller.
Two heads.
You do a vacuum really nice with it.
Yeah. And they have. I haven't seen it. Have you seen the clavicle, the shoulder piece that to teach
Shoulder distance.
No, I haven't.
I've heard
Shoulder
about it, but I
pads.
haven't. But it's shoulder. Yeah, it's something you put on the baby. I haven't
Is it a
seen
different baby or it's like a?
I heard it's something that just goes on here. It may just be in the design phase.
Yeah.
Like you can
To get it
bulk
stuck.
them up.
Well, and so you can feel what when you're trying to.
Oh, I see.
They're developing a postpartum IUCD module for
That's
I saw
so
that.
Yeah, probably at the booth, right? No, you probably went to one of the sessions.
Actually, at the reception.
At the reception. Oh, that's right. Yeah, I was with Mom and Natalie.
Party talk, you know.
Okay. Right. So here.
Okay, I want to help her. Who wants to be my helper? All right. Thanks. Let's see. So you're baby.
Yeah, baby Jess. Delivered.
Oh, look at my baby!
Good job. That was some masterful. Let's get this baby
Oh,
dried
they told me it would be hard.
Oh, you did a great job. You did a great job. Is this your sister or who?
I did it.
Or this is the housekeeper. Thank you.
I run the place.
Thank you for all your help.
You're so welcome. You did such a great job.
Great. Okay, let's make sure you feel all right.
Yeah, I feel great.
Oh, do you have a
I feel
name?
so good. Yeah, Elvis.
And we talked about the oxytocin.
That or any of me.
You were just having one baby, weren't you? I don't feel anybody else in there.
I hope not.
I'm gonna give you the oxytocin
They told me I was going to have
now.
one baby. Ow!
See you. I thought you weren't even gonna notice.
I wanted twins till I had one, and I thought, oh my god.
Yeah.
You wanted twins because you thought it would be fun.
Because I was young and I tried to get it.
You wouldn't have to go through labor twice.
Yeah.
Second kid was easy.
I'll just pick this cord tie up from the impeccably cleaned floor. Knowing that
My floors are.
the 3-second rule really does exist in this
Our
house.
housekeeper has cleaned the floor very well.
Right, right. And then I'll scavenge another tie off of this baby.
That's why it's so important to be prepared.
Maybe we'll use a clamp. That's a great idea, actually. So we'll put this on. Why are you
So we checked the baby, did
So
oxytocin.
the baby's gotten
It's been a minute.
blood from the placenta now, and we're gonna
My own home.
Okay. What hurt it?
No, you know this part doesn't have any nothing to do with it.
Yeah, exactly. As long as baby's breathing. And so before the placenta is delivered is not a typical time for postpartum hemorrhage, right?
That's right.
Okay.
It can happen. Usually it's associated with like an eruption, or severe rupture maybe.
And I'm keeping the simulation really vanilla at this point.
Yeah,
It's like in a way an IUD.
Good, and you're checking it. Let's
is still in there, so it's going to be big.
It feels high and big. Okay. So a little bit of
You're bleeding in the
bleeding
bucket.
here.
Awesome, Peter. That's how I moved it.
Okay. Oop, I felt the cord lengthen.
That's another sign that it's releasing.
Okay, so I'm going to put it closer here. And then.
What's
how
it
do I
called?
know that there's-
Guarding the
Guarding
uterus.
the uterus and
How do I know that there's a contraction? Am I feeling
I'm feeling
oh,
it.
ask
I'm
her.
feeling
Need
it.
to ask, yeah, or feel. With
So
the
I really-
placenta
I
in,
really
it's kind
don't
of hard to
feel
feel.
it. Am I supposed to be?
You
feeling
can't
it?
You
really-
can't
you
with,
can't
with
really
this
while
in.
you're-
You can in a real mother.
It's not big, yeah, that's a limitation of the simulator. You can't really
Okay.
make it. Yeah, I can, as a simulator, push up a little bit more.
Okay.
Yeah.
But it's hard to hold on to that and do what needs to be done to
To
help
be
the
done.
placenta deliver.
Right.
Okay. Okay.
And some of that may be my limitation. With
Yeah.
more practice, you know, proficiency doing this, I may be able to do it better.
It's like doing heart rate and breathing for the same time for the meaning.
And so I missed reading all of my script on. So you were asking about guarding the uterus, and so the reason why you guard the uterus is so you don't invert the uterus because it's a bag and you can turn it inside out.
Right.
Yeah.
And if somebody was really screwing that up, I could actually unstrap the. I could reach up here,
Oh, if they
unstrap
really
the
yanked
uterus, and I
somebody,
could
they could just
have
give it to them.
the
Pull the
whole.
whole
I could,
shebang out.
yeah.
And say, yeah,
So you've just delivered the
You
entire
just,
uterus.
you just, what are you going to do now?
you've inverted the uterus, and that's a lethal
But
problem.
I'm not going to do that now. So,
Okay.
and I wouldn't do that unless I had somebody who was really acting arrogant
Instead of
and not
two
paying
people who are
attention.
on their knees right here. So I still.
So if it's not giving, is it not time?
Okay.
Okay.
And then you wait for the next contraction.
Yeah.
Yeah.
And sometimes you could just take the time and have them feel what it feels like to wait for the next contraction.
Okay, so things feel pretty quiescent there now. Oh, and now here comes the placenta. So I'm
Oh, that feels good. Ah.
gonna get rid of it.
Oh.
And now I'm gonna.
Oh.
So
What
is
is that?
This
Is that my second baby?
Is that your second baby? Kind of.
and we'll look.
There's somebody with big eyes just looking in at you like, what are they doing? Yeah,
So that feels pretty good.
Yeah, she works here. You come in
Yeah.
with the bag.
Feels
she's
like-
back there.
Feels like the uterus is clamping down.
Yeah.
Well, here you
Is
can.
it the right position?
You can feel it too.
Yeah.
Looks pretty central to me.
Housekeeper, could you hold my baby while I do that? Would you mind?
Just change my gloves.
How do I do it?
Yeah, if you just feel there, it feels pretty firm, like
Okay.
it's organs. Yeah.
So what would I do?
That's good.
What if it was up here?
When did you pee last?
Oh, not before I went into labor, like at home.
Well, do you feel like you want to do that now?
Maybe, yeah. I guess I do.
Maybe,
Can you
maybe.
get it off?
Everything's
Okay.
confused.
Yeah.
We'll help you.
Okay.
Okay,
Okay.
we did that now.
Okay, back.
So let's check it out. Is it in the center this time?
Yeah.
You did a great job.
Okay. So we can probably, are you ready to have your baby back? So you can.
Yep, that's good. You guys did a great job. See, oftentimes inappropriate controlled cord because
Where's our?
I didn't change my clothes.
Oh, you had two pairs on.
I had two
And you didn't
pairs
take
on.
And
the
wait,
right
did
pair
you
off.
take the second pair off to do the court?
To do
To
the
take care of the
cord.
cord.
and I didn't notice that either. I'm sorry. I should have.
Right.
Well, and that was
Yeah.
something.
I didn't wear gloves at all. Whoops.
You would have been real
Just
nice.
I tell you, this process.
We're fast forwarding a little bit here today.
Well, and we are a little bit. With the two trainings, we've got like a mess on that table, but we'll have protective. We have protective eyewear and all of that, and gloves. And we actually have long gloves, which would be coming up next if we get a chance to get to it. So, yes. So you will see people who watch the training who can tell you exactly what they're supposed to be doing, and then they'll do some things like this.
Okay, so
So I'll put this again. Okay. Okay, so cord is cut.
I have seen such awful things with controlled cord trips. It's scary. Have you watched people do births and you've been out there?
Not
yet.
nearly in a,
Watch
you know,
how,
big numbers.
watch how people.
And I sort of, I think
Not.
that's part of the misgiving of including it for everyone, isn't it?
I worry about it a lot, the way I see it practiced. I am convinced
Even
that we're doing more
even
harm than.
skilled birth attendants. I mean, we're not talking about if the cleaner being taught, because
Yeah.
we haven't been teaching cleaners.
No, you watch the doctors in a training, you know, and the
Put their
midwives,
foot up
and
on.
they. Yeah, so,
So,
what do you,
so here's what you'll see.
Water skiing.
So yeah, here's what you see. Okay, are you feeling a contraction?
yeah.
Okay. So do let me know when it's gone.
It scares me.
And you can break these. And we broke one in Zanzibar. Okay. And is that contraction over?
Yeah.
We'll keep pushing because I just need to get it out. I want my tea break. So
What-
yeah,
so-
you will see.
And what I've done as a facilitator, when I see that happening, I think a really good thing about Mama is that you can open this up and you can allow people a window inside, and you can say, "Do that again, Sherry," and watch come over here and watch what's happening with the cord.
Wow.
It's not pulling the placenta out. So give a nice steady downward traction that you need to do, and you can see that does.
It's kind of that curve of Keras, although we don't actually talk about that in
But
this
just,
training.
and people, they have an aha moment when they see that as opposed to, you know,
When you're
pulling
doing
up
this,
and
yeah.
it's not
When you're
going.
pulling up, it's not.
And it's
It's
interesting
not-
that people do even think that,
Literally
you know,
pulling the
you'll
cord.
see a little bit of rocking at the bottom. That's one thing, but seeing it's amazing what you see. It's
Yeah.
really true.
Okay.
So, and you can certainly see it, and you play the role of the mother, but you also play the role of the facilitator by saying, okay, so now remember we're supposed to do slow downward finger there.
So
So, yeah.
I have a much different understanding of rolling the placenta than I did before. I
Good.
had.
How were you trained?